Good morning, everybody. Okay, you have to say good morning. This is okay, now I know that we're all really here. I hope everybody had really good evenings and slept very well and have come full of energy for day 2. And I really hope that many of you were at the reception last night where we heard some new commitments from some of the host organizations, and these are commitments that are really exciting. We will be continuing to run the commitments during the day, so any of you who missed them will actually see them. So before we go into day 2, a couple of announcements. The first is, please, can anyone who forgot to return their headset yesterday remember to return it today? That means that they can get recharged, the batteries, and then are available to use. And if everybody could please try and remember to return the headsets so that everyone can have a pair. The other thing that we want to do is to reserve row 8 for people who will be speaking on panels and on stage. So anyone who's going to be speaking on a panel, if you're speaking this morning, please sit in row 8. If you're speaking this afternoon, go to row 8 after lunch. And it's just to make it easy to find everyone, because the team's been running around a little bit, making sure that they've got everyone. And if all people who are going to be speaking could just make sure that they are backstage 30 minutes before your panel or your presentation is up. And that's just so that you can get mic'd up and ready to come out. Okay, so that's all the boring stuff. And now we can go into the fun stuff. I won't go into everything we learned yesterday. The team have been working really hard behind the scenes and are producing a video with some of the highlights of the learning. But I did just want to say 2 things. First, a thank you to all of the panelists who spoke yesterday. It felt as if there was a lot of learning. We were hearing some things that we already knew, but hearing about them in different ways and with different intent and motivation. But then there was also a lot of new information that people were taking in. I hope everyone's taking the opportunity to speak to the panelists outside so that you can actually follow up with any additional questions, etc., that you have. The big, 2 big words for me. One was intersectionality. I've always, as an activist on women's rights and children's rights, believed in intersectionality in terms of approaches. What I really learned a lot yesterday was listening to the science of the intersectionality of the causes of death for children. And it really confirmed in me that if you have that kind of intersectionality in the mortality, we absolutely cannot afford not to have real intersectionality in terms of our solutions and our approaches and our collaborations. The second word was accountability, and we will be seeing a lot more of that word today. We're going to start today with two sets of conversations. Dr. Endi Waziri will be working very, very hard. She has two panels that she will be introducing. And those panels will be looking at the power of vaccines. We have country teams with a specific partner who will be talking very much about partnering to increase coverage of pneumonia-fighting vaccines. So please, let's start this morning by welcoming Dr. Endi Waziri.
That's order.
Good morning. Good morning. It's too early in the morning to be quiet. And this morning we have an interesting panel. We'll be talking about the power of vaccines. Yesterday, one of our sisters, Chika, unfortunately I think she left this morning, told us that vaccines liberate. They bring freedom. And that's the reason why we can all sit here this morning without wearing our mask. We can have a physical meeting. Imagine 3 years back when COVID struck. No one else thought that we'll ever get back together, but the vaccine liberated us and gave us an opportunity to go back to normal lives. So vaccines liberate. This morning, I have a very, very highly respected panel from some countries that will be telling us some of their experiences and what they plan to do to stop childhood pneumonia. I have Dr. Ubafara Ahmed, who is a family health advisor from the Ministry of Health and Human Services in Somalia. And then Dr. Binyam is the Deputy Director, Save the Children, Somalia. Dr. Khadijat Abrene, Director of Reproductive Health, Ministry of Public Health from Chad. Dr. Dixon Awa, who is the Country Director of Malaria Consortium. Dr. Cisse is the National Coordinator for the Expanded Program of Immunization, Ministry of Health and Public Hygiene, Guinea. And finally, Dr. Kabore from the Center for Vaccine Innovation and Access at PATH. PCV is the most effective life-saving vaccine that half of the world's children do not get, including children in Somalia, South Sudan, Chad, and Guinea. But this is about to change as all 4 governments have made commitments to introduce the vaccine by 2024. Together with rotavirus vaccine, if non-government vaccine partners will support financing and operational delivery. At the same time, India and Indonesia are making great strides with PCV introduction and have many lessons to share. Partnerships between Ministry of Health and local NGOs can be transformative in accelerating vaccine introduction and scale-up. Gavi and UNICEF are committed to testing new approaches to reaching the most vulnerable children, especially zero-dose children who have not even received 1 dose of the DTP vaccine. Dr. Uba, pneumonia is the leading killer of children under 5 in Somalia. About 14,000 children die every year from pneumonia. The PCV could prevent 4,000 of those deaths. Somalia is among the last remaining countries to introduce PCV in Africa, what are the plans of the Ministry of Health?
Good morning to you all, ladies and gentlemen, colleagues. Thank you so much, Dr. Ali, for this question. As I said, Somalia is recovering for decades of conflict and aggravated by drought. The government has made huge effort in improving the health for Somali people. Childhood pneumonia is a major public concern for Somalis and one of the leading causes of mortality of children under 5, as you said, together with diarrhea. The government is committed to reduce this trend. We established a child health technical working group composed all stakeholders, UNICEF, WHO, Save the Children, Somali health professional, a coordination platform that brings together all these specialists to review new policies, to address pragmatic barriers, and also to develop a child survival action plan, to preventing by vaccination, protecting, improving exclusive breastfeeding, reducing indoor air pollution. We also demonstrate a progressive on improving our coverage of pneumonia-fighting vaccine, as I said, Penta and measles yesterday. Somalia continues to leverage resources available for COVID to improve availability of oxygen and also amoxicillin. I do agree with you. PCV is a game changer to further reduce this mortality, as you mentioned, and not only pneumonia, but also meningitis, hospitalization, the number of the cases. The federal government is committed and working towards introducing this vaccination, BCV and Rota together the upcoming year, the 2023-2024. To facilitate this, the government has taken a step towards. We have established, we have our Somali immunization policy and multi-year comprehensive plan for immunization. It included the introduction of PCV in our scheduled immunization routine. Also, we have constituted a task force that will take the application of introduction of PCV and Rota. It composed, as I said, Somali government and its partners. The government is committed to introducing, recently have appointed National Immunization Technical Group who will take the lead. However, we are facing a critical challenge, mobilizing domestic resource to meet the co-financing obligation of Gavi. To realize this critical goal of introducing Rota and PCV in the country, we look to Gavi and our partner to support with waiver of the co-financing and commit, especially in initial years of introduction. I always thank our partners for their technical support and looking forward to working together with them in this step towards introduction of 2 important vaccinations.
Thank you very much, Dr. Uba. Dr. Bian, Save the Children has been conducting an important trial with other partners on the impact of PCV among displaced children in Hargeisa to generate evidence on appropriate vaccination strategies for crisis-affected populations. Can you share any of those results and how you are supporting PCV introduction in Somalia?
Thank you very much for the opportunity. I just stepped in for Dr. Bobe. You could not make it last minute. But of course, pneumonia and health intervention in general is something close to my heart, so I'm happy to be here. Pneumonia for Somalia in particular is a very important issue because it accounts for 25% of under 5 mortality, whereas the global figure is around 14. So pneumonia is a big issue, and I think this forum is probably most important to us, more than any other country. So, been a number of concerted campaign effort for Somalia to roll out PCV. It didn't work because of partly the co-financing challenges which Dr. Uba mentioned, but also, we had threshold challenges in the past to be eligible to PCV, and we've been campaigning with Gavi and a lot of other partners. So to help that campaign and to boost that effort, we conducted a PCV in collaboration with London School of Hygiene and Tropical Medicine, we conducted the pneumococcal carriage baseline survey in OIDP camps around Hargeisa. Of course, following the survey, we also piloted PCV vaccines in children with a sample size of around 454. And what we have found out was a dramatic reduction up to 80% following the PCV trial in those places. So we know PCV works, it's effective, it can dramatically reduce mortality. So hopefully that is evidence we are continuing to use for introduction of PCV and in Somalia in collaboration with the government.
Thank you, Dr. Binyam. Dr. Khadija, like Somalia, Chad is losing about 14,000 children to pneumonia each year, and there is no PCV in Chad. Chad has even more children dying from diarrhea. How is the ministry thinking about these two vaccines, which together could help the country take a big leap forward in achieving the SDG 3.2 progress?
Ok, merci beaucoup. Et nous remercions d'abord les organisateurs de ce forum pour nous avoir donné l'occasion de venir partager nos expériences et aussi d'apprendre des autres. Donc, le gouvernement du Tchad remercie aussi ses partenaires traditionnels qui ne cessent de l'appuyer pour la survie de l'enfant, pour améliorer la survie de l'enfant. Comme vous le savez, à l'instar des autres pays de la sous-région, les infections respiratoires, c'est-à-dire la pneumonie, le paludisme, la diarrhée, de même que la malnutrition, constituent les principales causes de morbimortalité chez l'enfant. Donc, nous, pour atteindre les objectifs qui sont inscrits dans le plan national de développement sanitaire 4e génération, qui s'étale jusqu'en 2030, qui consiste à réduire la mortalité infantile de 122 pour 1000 naissances vivantes à 72 pour 1000 naissances vivantes. Donc, l'introduction et la mise à échelle rapide des vaccins contre le pneumocoque et une couverture élevée et durable des vaccins contre la rougeole, la diphtérie, le tétanos et la coqueluche, ainsi que l'introduction du vaccin contre le rotavirus sont très indispensables et sont une urgence pour nous. Maintenant, pour revenir aux deux vaccins précédemment cités, le processus d'élaboration de ces deux vaccins dans le PEV de routine est déjà lancé. Donc, la soumission de la demande à Gavi sera faite d'ici juin 2023 pour le financement de leur introduction après la validation par le CCIA. Et aussi, nous avons révisé les outils de gestion de la vaccination en prenant en compte ces deux vaccins. Maintenant, pour un bon rendu de ces vaccins, donc nous avons aussi quelques défis. Et c'est vrai que la liste n'est pas exhaustive. Parmi ces défis, nous aurons un renforcement des capacités de ces prestataires qui sont au premier plan et à tous les niveaux de la pyramide sanitaire. Donc maintenant aussi, il faut faire adhérer la communauté à ces nouveaux vaccins et maintenant à travers les actions de sensibilisation et développer aussi des stratégies adaptées pour vacciner les enfants de 0 à 23 mois. Et aussi organiser les campagnes de rattrapage chez les enfants de moins de 5 ans. Et aussi un autre défi de taille qui consiste à l'approvisionnement régulier en vaccins. Et construire aussi des nouveaux sous-dépôts et ainsi que le fonds accélérateur de l'équité qui permettra effectivement d'atteindre les enfants 0-12. Donc, merci beaucoup.
Thank you, Dr. Khadija. Dr. Dixon, your team at the Malaria Consortium has been working with the ministry for some time now. What are your plans to increase that support? And how do you think an NGO can be most effective at supporting ministries of health?
Thank you very much for the question. And since Malaria Consortium happens to be a name that sometimes can be misperceived, as us working only for malaria or malaria disease, I think I'll take a few moments to just speak about what Malaria Consortium is as an organization. We'll be celebrating our 20th anniversary this year. It was founded in the UK and it's headquartered there. We have as mission to save lives and promote health with the introduction of evidence-based approaches that would combat targeted diseases and also to promote universal health. So coming now to the question of our collaboration with Chad, we have been in Chad for quite some time, say about 8 years, and we've worked very closely with the government of Chad and have achieved many things. Most prominently is the recent work that we've done to assist the ministry in developing a pneumonia control strategy. Now, this strategy is not treated as, say, a one disease item. It's treated a bit more broadly because the country of Chad has committed to the reduction of disease burden, especially pneumonia. But they are still looking at it in a more holistic and integrated way. And so they are, so this framework includes the fight against malaria, diarrhea, and then neonatal health as well as malnutrition. Because if one, like many speakers have said yesterday, I don't need to belabor that, but as you well know, if somebody is malnourished, then they have almost limited chances of fighting any other condition. So Malaria Consortium is working on this broader child survival strategy with the government, and we help them to identify needs and see how we can do, to address these needs which are of priority to the government. So like I just mentioned, we have worked in creating this strategy. But before creating this strategy, we did formative research. And in the course of that research, many things were brought out. There was the issues of, say, human resources. There were issues of finances and a lot more of other difficulties, even capacity. So what we have been doing with them has been to prioritize this based on the strategy that Dr. Khadija mentioned, which is the government priority for 2016 to 2030, which is to bring down, this disease burden. And so once we captured the issue of the absence of PCV vaccine, this got picked up by Every Breath Count as well as Gavi, and so they have led in the effort of supporting the government and to see how they can rally other resources and partners around the government of Chad to work and see how we can be able to come up with an application for Gavi that would meet some of the requirements so that Chad can also benefit from the funding as far as this PCV introduction is concerned. So that advocacy continues to go on. Malaria Consortium has also offered, to help the government come up with different strategies which they can use, to achieve some of the things that they would love to achieve, especially in the area of, transferring competency to local staff. So we have also, put a bid which, if that is successful, we'll be able to come in and even support them with our global experience in areas that we have succeeded very well and bring this success lessons so that they can also be applied in the context of Chad. We would like to also help them with the mobilization of civil society organization and grassroots organization because their next 16-year strategy is titled a community-based strategy. And like Dr. Khadija mentioned, the community is where the strength is. And given the different difficulties in the country of Chad, whether it is communication or it is, mobility, so we truly feel like bringing the resources, bringing the capacity at the level of the community, it can really help, to mobilize and have the sort of breakthroughs that we are interested in achieving together. Now, for what other NGOs could do, Malaria Consortium is basically taking the lead in some of these activities for right now. And we know that, Gavi, Every Breath Count, and other organizations like, Save the Children, of course, not leaving out the UN agencies, WHO, UNICEF, all of them are in the country doing, great work. And we truly believe that there is so much work, and any organization that feels inspired the way we are to come and support. We are not seeking a monopoly in doing the implementation of all of this. We are just there right now because we are in country and we have the capacities that we have. So thank you very much.
Thank you very much, Dr. Dixon. Dr. Cisse, Guinea is considering the introduction of 4 new vaccines: PCV, rotavirus, malaria, and HPV. I tell you, that is a huge task. How will the government prioritize which vaccines to introduce first? Do you go with the ones that save the most children's lives first, or are there other considerations?
Ok, merci beaucoup, madame. Tout d'abord, je voudrais remercier les organisateurs de ce forum pour l'intérêt et l'accompagnement qu'ils accordent à notre pays. Et hier, 2 de mes prédécesseurs, qui sont les plus hautes autorités de notre pays, étaient ici. Ils ont essayé un peu de décrire le contexte dans notre pays pour comprendre comment fonctionne la vaccination en Guinée. Et le contexte, il est caractérisé par la survenue d'épidémies multiples et simultanées et qui, dans notre pays, entraînent énormément de défis. Parce que face à ces urgences, alors, le gouvernement est obligé de réorienter les ressources et aussi les priorités changent naturellement, et en même temps, le personnel de santé, alors qui est affecté par ces épidémies, parce que le personnel de santé a payé un lourd tribut au cours de ces épidémies, le personnel de santé aussi, et ce personnel doit être renforcé. Aussi à cause de la peur née de la létalité élevée induite par ces épidémies, alors nous avons assisté à une faible adhérence à la vaccination et même à l'utilisation du système de santé. Donc ça fait que les indicateurs sont au plus bas et nous avons notre couverture vaccinale est en deçà de 50%, autour de 47%, comme indiquent les données WINIC, les données des enquêtes WINIC organisées par l'OMS et l'UNICEF. Donc, ceci dit, le pays travaille actuellement à renforcer son système vaccinal. Nous avons fait une analyse de la situation qui nous a permis d'élaborer une feuille de route alors pour permettre à la relance du système de vaccination, mais en même temps, de manière générale, un renforcement global du système de santé. Et ce sont des préalables importants à l'introduction de nouveaux vaccins. D'autre part, nous travaillons avec des partenaires comme PAF et d'autres partenaires, l'USAID, l'UNICEF, et des partenaires locaux pour conduire un processus d'élaboration d'un document de référence pour orienter l'introduction de nouveaux vaccins. C'est-à-dire quel est le vaccin qu'on doit introduire et à quel moment. Et nous avons utilisé à cet effet un outil qui s'appelle Capacity. Et cet outil a des critères auxquels doivent obéir l'introduction de nouveaux vaccins. Il y a l'efficacité, il y a l'équité, et il y a l'approvisionnement, entre autres. Donc, cet outil-là va être utilisé par les instances de gouvernance que nous avons, c'est-à-dire que nous avons le GTCB, le groupe consultatif, le groupe technique consultatif pour la vaccination et le comité de coordination interagence stratégique, le CCA stratégique, qui vont utiliser cet outil et les différents critères qui vont être appliqués aux différents vaccins alors pour décider de l'introduction. Et ces instances de gouvernance dont le GTCB doivent, pour réussir cette tâche, doivent être bien entendu formées, leur capacité doit être renforcée. Et c'est pour cela, hier, nous nous sommes entendus avec la Fondation Bill et Melinda Gates et Gavi, alors à ce qu'un programme de renforcement de capacité puisse concerner les membres de GTCB afin qu'ils puissent réussir à accomplir leur travail. Et d'ores et déjà, nous sommes heureux que la volonté politique et le pragmatisme de nos autorités nous amènent à nous engager pour introduire d'emblée ou dès au départ deux vaccins, à savoir le Rota et le PCV. Mais il reste entendu que l'introduction de ces vaccins-là, bien que l'engagement politique est là, doit obéir au respect de ces critères cités. Donc le poids de la maladie, bien entendu, est un facteur important et nous y tenons compte. Et c'est pour cela que nous sommes déjà alignés sur les deux premiers vaccins. Alors pour la prévention des maladies, des deux maladies, la pneumonie et la diarrhée qui sont les plus grandes tueuses des enfants de moins de 5 ans.
Okay. Thank you, Dr. Cisse. Dr. Kabori, what tools can an NGO like PATH offer to ministries to inform new vaccines introduction? And are these tools being used effectively? How much of new vaccine introduction is actually evidence-based?
Thank you very much, Mr. Chair, and thanks to the organizers for having us here. That's a great question that we have been asked to address. So as far as PATH is concerned, when it comes to new vaccine introduction, we essentially go by two sets of tools. The first set of tools are actually the tools that have been developed by global organizations like WHO or Gavi. Those organizations have developed a number of guidelines that countries and partners need to consult when it comes to new vaccine introduction. And for instance, WHO has a guidance on specifically how to go about new vaccine introduction. I also believe that Gavi usually has vaccine-specific guidelines that countries and partners need to consult to proceed with vaccine introduction. But besides those sort of generic tools, we also have our in-house or specific tools and approaches that we use to support countries to make decisions and implement new vaccines, which, for instance, include reviewing and summarizing the burden of disease in the country, like incidence, prevalence, and hospitalization data. And then we also usually support countries with costing and cost-effective analysis. With regard to costing, happy to indicate that PATH, for instance, has developed costing calculators for PCV, rotavirus, and even HPV vaccines. And those tools can be consulted on PATH website, and it's good to see that they are available in both French and English. And then we usually also do advocacy and stakeholder engagement at early stage to ensure that key stakeholders are all aligned and supportive of the initiative to introduce a new vaccine. And depending on the case of vaccines, for instance, for HPV vaccine, what PATH has done with many countries is supporting the implementation of feasibility demonstration project, sort of pilot project, before countries are able to scale up the vaccine introduction. This has been done in a number of countries in Africa. So there have been many instances where PATH did that support. For instance, for HPV, we supported more than 20 countries to introduce the vaccine with the approaches I just described. For a malaria vaccine, which is trendy now, we also supported countries which recently submitted applications to Gavi, and some of them have been approved. And other vaccine, for instance, that we're supporting is typhoid conjugate vaccine, that we have, which is another new vaccine, but that which we have introduced, supported the introduction in a number of countries, like including Liberia and Zimbabwe, who are the first countries to introduce that vaccine in Africa. So coming to the second part of your question, how much new vaccine introduction is evidence-based? That's a very interesting question, because sometimes we need to avoid perfection being the enemy of the good, because at some point, if you have a minimal body of evidence, you can make a decision instead of waiting for perfect data. Like if you, at the country level, you cannot wait to have granular disease burden data at the provincial or district level before you make the decision. Speaking of PCV or HPV, for instance, sometimes country may be interested in what are the specific serotypes or genotypes that are circulating in my population. If you are waiting to have all that information before you make a decision, you are going to further delay it, and this delay has an opportunity cost. So I would definitely encourage countries, especially those that are currently looking at introducing PCV, to proceed with introduction, given that I think in the Africa region country, the first countries that have introduced PCV has done so more than 10 years ago, and we have enough evidence to show that the vaccine is working. So they should definitely proceed with introduction, and I'm happy to indicate that we are collaborating with Dr. Cisse and the Guinea EPI to see how we can work together to support them to introduce the various vaccines that he just mentioned. Thank you.
Thank you very much. In terms of evidence, we've also heard from Somalia. In the study they did amongst about 400 children, they saw an 80% reduction in death. So that's evidence that is enough to push Somalia, Chad, Guinea, and Sudan to introduce PCV. Thank you very much, my great panel. And
Thank you.
Thank you for the great conversation. While they take their leave, I'll introduce the next panel as they come in. So I have Dr. Prima Yusufin, who is the Director for Immunization Management, Ministry of Health, Indonesia. Dr. Atiak Anartati, who is the Country Director for Clinton Health Access Initiative in Indonesia. Dr. Sumita Ghosh, Additional Commissioner in charge of Child Health, Federal Ministry of Health and Family Welfare, India. Dr. Naso Mohammed, who is the Senior Immunization Technical Officer at John Snow. And then Dr. Amy Chikomola, Director of Immunization, Ministry of Health, DRC. And then Dr. Amin El Morid, the Senior Program Officer, Bill and Melinda Gates Foundation. Good morning, and thank you for joining us this morning. We'll go ahead and just start. So, Dr. Prima, Indonesia is now rolling out PCV after announcing the introduction at the first Global Pneumonia Forum, a forum like this. Can you share an update on current PCV coverage? And what are the challenges that you have faced in rapidly achieving high coverage? And how can non-government partnership help? You have 3 questions in one.
Yes. Good morning, dear all. Thank you, Dr. Andy, for your question. For your first question, pneumococcal conjugated vaccine was introduced in Indonesia in phased manner. Started in 2016, and in last year, September, has been rolled out nationwide. The vaccine is delivered to children 2, 3, and 12 months of age, co-administered with other vaccine. We believe that through the improved access of PCV vaccines, all vulnerable children in our country will be protected from one of the major threats health threats, and therefore we can achieve the goal to control pneumonia. According to data released by WHO and UNICEF, COVID-19 pandemic also driver for declining the coverage of third dose of PCV in Indonesia from 27.7% in 2019 to just only 12.6% in last 2021. And for your second question, the crucial point of the new vaccine introduction is to ensure sustainability. This includes not only to ensure the availability of the vaccines, but also how the funding been sustained and how the high coverage can be achieved. The success of PCV introduction will surely need support from all stakeholders, including subnational government. What we find challenging for us is how commitment of the local leaders are gained and maintained. Also, all necessary resources been allocated. The success of PCV introduction will surely need support from all stakeholders. And the other challenges is during the COVID-19 pandemic that has driven the decline of coverage of all childhood immunization in Indonesia. Public fear of COVID-19 transmission has hindered parents and also the caregivers from bringing their children to immunization posts or health facilities to get vaccinated. Another thing is the more vaccines being introduced, the more injections will be given to a child in one visit. So this concern of multiple injections has been an issue in several areas where the health workers are not confident enough to administer the vaccines, and the parents are also worried of the child getting adverse reaction after immunization. Moreover, vaccine hesitancy is still found, not only due to the religious or belief reasons, but also the lack of knowledge as well as awareness of the importance of vaccines for the children and all the community. And for your last question, what we expect from the non-government partners is to support us to ensure the success and sustained PCV introduction, including financing, advocacy and communication, capacity building, service delivery, monitoring and evaluation, and also support to assess more affordable vaccines. Maybe that. Thank you.
Thank you very much, Dr. Yusufin. Dr. Anartati, Indonesia was able to secure the much more affordable Gavi price for the PCV. But moving forward, should the country be looking for a more affordable vaccine?
Yeah, good morning, everyone. It is my pleasure to be here together with my excellent Director, Immunization Manager, Ministry of Health Indonesia, and also for hosting me here. Dr. Andy, back to your question, my short answer is yes. And given that Indonesia is the fourth most populous country in the world after China, India, and USA, and also one of the highest baby cohorts, it's around 5 million, and also the government plan to introduce other new vaccine and will be national scale up, which is rotavirus vaccine and also HPV vaccine. So anything associated with the increasing cost of the vaccine procurement will be taken into main consideration. So from those new vaccine, PCV carries the most risk in price cliff when Gavi price or AMC expired in 2028. So PCV may jump up to 6 times with commercial price from $3 to $18 per dose, especially if no new PCV type comes to the market. So the government national budget may not sufficient enough to cover the PCV costs because in post AMC, it's take of maintaining other routine vaccine. So any option for assessing upcoming affordable PCV price will be favorable, either by involving state-owned local manufacturer like Bio Farma through tech transfer or business collaboration, or maybe by other possible global price reduction, such as extending AMC-like price maybe, or with UNICEF SD procurement. So another possibility is by involving private manufacturer in Indonesia to develop tech transfer of PCV faster. As far as I know, there is a new private manufacturer had been committed to produce PCV 13 by 2028. However, the price may need to be negotiated for affordability. So CHAI, as one of the MOH partner, together with other partners like UNICEF, WHO, and also Gavi, we are looking for any possibility for procuring PCV at an affordable price. CHAI will continue to supporting MOH in the decision-making process by doing cost-benefit analysis that include various mechanisms in choosing affordable PCV. The end goal is for all Indonesian babies to have access to the most life-saving vaccines, such as PCV, to prevent pneumonia as a second leading cause of death for children under 5 in Indonesia after rotavirus, after diarrhea. In addition of that, PCV price post-AMC could affect other low-middle income country and also middle-income country that use the AMC scheme in PCV introduction. So maybe global health policy stakeholders should consider designing global policy option for countries to be able to access more economical price for PCV post-AMC. Thank you.
Thank you very much, Dr. Anartati. Dr. Ghosh, India has achieved remarkable gains in PCV coverage during the pandemic. Can you share what the statistics are currently and how the public have reacted to the vaccine?
Thank you. Good morning to all. Thank you for mentioning India's progress in PCV. I'd like to tell that it was introduced in a phased manner in India. Pneumonia causes 17% mortality in under 5, and it's largely preventable, especially with vaccination. 38% of severe pneumonia can be avoided. So taking all this into consideration, 2017 it was first introduced, but from 2017 to 20, only in 5 major burden states they were there. After that, COVID came, and we all know. So the next phase of expansion that happened in 21, and that happened very, very rapidly. It was decided that it has to be rolled over over the country. So by October end 2021, it was rolled over all over the country in all the 36 states and union territories. So now, presently, for last 16, 17 months, it is there for all birth cohorts, that is the 26 million birth cohorts annually. So this rollout has come out because it came in a phased manner. It has come out with a lot of preparedness, awareness, generation. Some of them I can mention. There is a digital online tool prompt which actually monitors, collates data, shows the status of completion, shows the KPIs. So that way it can be monitored how it is being rolling out. Then a lot of IC materials, awareness materials were prepared, handouts, FAQs, then so many in many languages, like India many local languages, Hindi, all this were rolled out for awareness generation as well as for, even the peripheral worker training. The training also happened in cascade mode and at the national level, district level, state level, both online and on physical mode. So with this kind of preparedness, training videos were prepared for the peripheral workers. So this kind of preparedness, even during the height of COVID pandemic, it happened when the whole country was busy in rapidly rolling out COVID vaccination for such a large population in a very, very short while. But the progress has happened. And the coverage, which the latest data shows that PCV1 coverage is 81.8%. Of these birth cohorts which have happened over this period of time. PCV2 coverage is little less, 80%, and the booster PCV that is given at 9 months, that is coming at 72.7%. So we think that is quite an achievement in this last few months. The commitments of the national commitments, the state commitments, states all were on board with us. The partners' commitments, all our partners, immunization partners' commitments, and the role played by media. Media has, played a tremendous role. They projected that 50,000 deaths will be avoided annually. So that has again been a very big thing. The acceptance is quite high, as you can see from the figures. Actually, the success, it has been a part of the routine immunization, and it uses the same workforce, same kind of, scheduling, same cold chain, same kind of, health workers. So that way it has been possible. The acceptance is high. You can say in a recent survey which was conducted, the sample size was 1286 and acceptance was 75.5%. Refusal only was hardly 0.2%, and some concerns 2.8%. So we know that from the very beginning, this has been, the rolling out has been quite powerful, and it's totally domestically funded, and indigenous vaccine is now being used. And supply issues, yes, there might be sometimes, so that we are taking into consideration. And next, we want to increase the coverage, increase the quality, because there are some interstate variations. We have to look into those aspects. Thank you.
Thank you very much, Dr. Ghosh. Dr. Mohammed, what are the ingredients of success? We've heard so much from Dr. Ghosh. So what are the ingredients of success in the India's PCV story that other countries can learn from, and what was GSI India's contribution to that success?
Thank you. Good morning, colleagues. I'm glad to be part of this discussion, and I will add on what Dr. Sumita said. So in terms of the ingredient, the first thing is the strong government leadership and commitment, as well as the ownership of the whole process. This is really important for the success of the rollout of the vaccination. So India government take the lead in making sure that they coordinate all partners that are supporting the program, but also their commitment in terms of providing support to the program to make sure that the rollout went successfully. But the other thing is in terms of ingredient, as you know, the rollout happened during the difficult time of pandemic. So it's really important to have innovative ways of navigating through the challenges. So I'm not saying that there will be another pandemic for the countries to get prepared, but usually in the process of rollout, you might find some unexpected challenges, and therefore it's really important to have innovative ways of navigating through the challenges. As we heard from Dr. Sumita, there were some innovation around using the technology, like the prompt tool she mentioned about, which was mainly, the aim was mainly to do the quick readiness assessment to make sure that the states are ready. And it was difficult to do physical visit during that time, so the country developed that tools which helped to quickly do the readiness assessment to see if the states are ready to roll out. But you can see also there are other innovation to navigate through the difficult situation during COVID, like the online launching of the program at the state level. So those are kinds of the innovation that were used to navigate through the difficult challenges. So it's important to have that in mind, that there might be some challenges that are unexpectedly that will happen, and you need to have the way to navigate through. But the other thing is, it was mentioned also, the highest level of engagement, both from all partners who are involved in the process. And of course, this happened because of the strong leadership that are in place to coordinate those partners. In terms of the GSI roles in this, starting 2020, with support from BMGF, GSI had a dedicated team, both at national and states level for the 25 states that are introduced from 2020 to 2021, to support all aspects of rollout, starting from the planning, the rollout itself, but even after the rollout, continue monitoring the progress in terms of coverage and provide the need support to the states when it's needed, based on the assessment that are done. Thanks.
Okay. Thank you, Dr. Mohammed. Dr. Chikomola, could you please explain how DRC launched and used Mashako Plan to increase coverage of vaccines, including PCV13? How did COVID affect this effort, and how is vaccine coverage recovering? But first, tell us a little bit about that Mashako Plan.
Merci beaucoup. Je suis très ravi d'être parmi vous. Je vais parler effectivement, je vais dire un mot par rapport à ce plan que nous appelons plan Mashako. Il s'agit tout simplement d'un plan de revitalisation de la vaccination systématique que le pays a mis en place en 2018, à l'époque où il y a eu les épidémies de rougeole, l'épidémie de CVD-PV, mais il y avait également l'enquête mixte qui nous a servi de baseline. Les résultats de cette enquête ont noté que seulement 35% d'enfants étaient complètement vaccinés au pays. Et c'est ce qui a été à la base de toutes ces épidémies qu'on a vécues. En dehors de ces épidémies que je cite, il y a aussi des épidémies d'Ebola, épidémies de choléra, épidémies de fièvre jaune, et tout évolue dans un contexte d'insécurité, comme vous le savez. Le pays, il est grand, mais depuis 3 dernières décennies, on évolue dans un contexte d'épidémie, disons d'insécurité, qui fait à ce que le système de santé n'arrive pas à maîtriser toutes les épidémies parce qu'aussi les populations sont en perpétuel déplacement. Alors, face à cette situation, le ministère de la Santé avait invité ses partenaires, ses différents partenaires, ainsi que le programme élargi de vaccination pour discuter sur comment faire face à cette situation. Alors, la situation se présentait telle que la disponibilité des vaccins faisait défaut au niveau opérationnel, au niveau des centres de santé. Il n'y avait pas assez de vaccins. Au niveau des centres de santé, on n'arrivait pas à organiser des séances de vaccination de telle sorte que la population ait accès aux services de vaccination. Mais aussi, les suivis étaient presque abandonnés. Donc, il n'y avait pas eu une bonne coordination. Alors, à cette situation-là, On a sélectionné d'abord les provinces. Mon pays, en fait, compte 26 provinces. On en a sélectionné celles qui avaient un grand nombre d'enfants non vaccinés, celles qui présentaient beaucoup de jours de rupture des stocks en vaccins, et les provinces qui étaient en épidémie de rougeole et épidémie de polio. Donc, on a sélectionné 9 provinces dans un premier temps, et on a implémenté ce plan qui consistait à des simples interventions, mais efficaces, notamment améliorer juste le nombre de séances de vaccination, améliorer la disponibilité des vaccins au niveau des centres de santé, assurer le suivi des activités par un rythme hebdomadaire, mais aussi le suivi des activités en organisant régulièrement les supervisions et même les revues. Et puis, après tout ça, on devait valider les données de couverture en organisant des enquêtes de couverture vaccinale indépendantes. Alors, cette histoire, j'aime souvent la raconter comme une histoire d'amour entre le programme élargi de vaccination que j'ai conduit et ce plan, le plan Machako. Alors, dans un laps de temps, on s'était fixé l'objectif d'améliorer la couverture vaccinale de 15 points dans 18 mois. Mais curieusement, grâce à ces stratégies, on a amélioré la couverture dans les 9 premières provinces, plutôt de 27 points. Alors, c'était très bien. Et les provinces qui n'étaient pas dans Machako en ont bénéficié aussi et ont amélioré des 15 points. Alors, ça nous a beaucoup encouragés et on a étendu ce plan dans d'autres provinces qui restaient. Il faut mentionner que tout cela se faisait sous le leadership du chef de l'État, qui a convoqué un forum en 2019 lorsqu'il a constaté que la situation était catastrophique. Et ce forum a découlé sous forme d'une déclaration de Kinshasa, qui consistait à appuyer la vaccination et les projets d'éradication de la polio en RDC. Et à ce jour, on peut vous dire que depuis 2019 à ce jour, le pays contribue efficacement à l'achat des vaccins. Et c'est une moyenne de 18 millions par an. Donc, on est autour de plus de 70 millions par an de contributions du pays depuis 2019 à l'achat des vaccins. Cependant, comme dans toute histoire d'amour, il y a le bonheur, il y a le malheur. Le malheur vient souvent de l'environnement externe. Il y a la pandémie de la Covid, 2021. On a vu les indicateurs chuter et on a perdu quelques points. Donc, des 53% d'enfants complètement vaccinés, après les enquêtes de 2021, on est retombé à 41% d'enfants complètement vaccinés. Et cela nous a attiré notre attention. Nous avons rapidement développé la deuxième version du plan Machako 2.0, qui en fait a mis l'accent à consolider d'abord les acquis du plan Machako 1.0, mais a mis l'accent sur les stratégies avancées. Donc, amener le vaccin tout proche des populations. A mis également l'accent sur la recherche des enfants perdus de vue, la recherche des zéro doses, mais aussi la réduction des occasions manquées de vaccination. Mais alors, il y avait aussi un souci pour faire arriver l'argent auprès de bénéficiaires dans un court délai, et on a insisté aussi sur cet aspect-là. Voilà pour le moment, c'est le plan Machako 2.0 qui est en train d'être mis en œuvre au pays, mais l'enquête est en cours parce que nous validons toujours nos données par l'enquête. Et à ce stade-ci, nous avons espoir parce que, en comparant les données administratives que nous produisons, nous remarquons que 2022 est meilleur que 2021. Et nous attendons l'enquête des couvertures pour l'année 2022. Ça va être publié d'ici le mois de mai et pour évaluer encore nos performances. Je vous remercie.
Thank you very much, Dr. Chikomulo. I think we need to come and learn about the Machako plan. Dr. Morid, how did partners join the government to support these bold immunization strengthening efforts? And can you describe some of the specific initiatives that the Gates Foundation is supporting?
Thank you, Dr. Andy. And let me say first that it was an absolute privilege and honor to work alongside the government to to work for the Mashako plan. In fact, I was a consultant for Gavi at the time of the launch of the Mashako plan, and I was embedded in the Ministry of Health and working alongside my colleagues and now friends to implement and support the Mashako plan. So maybe the first thing that we did was total alignment of all the donors under the leadership of the Mashako plan. The targets that were set up by the Ministry of Health and the EPI program, all the partners used them as their targets to support the program. There was also reprogramming of the funds that were already available in the country to support these initiatives and targets that were implemented. In fact, also there was an agreement between the government and the financial and implementation partners that each province would have a donor and implementation partner lead, so that there would be joint accountability between the provincial governments and the donors in terms of achieving these targets. And in fact, we had a healthy competition between the provinces and the donors in the different approaches they were implementing, because we had, as Dr. Sikomola said, one joint monitoring mechanism. And that was also an innovation that was supported by the partner. We put in place a digital supervision app where we would check every month more than 3,500 health centers, and supervisor would check the availability of vaccines, the realization of immunization sessions, and all of this data would be directly go to the national level for monitoring. This app now supervises more than 10,000 health centers because, as Dr. Sikomola said, it was expanded. On the coverage survey as well, instead of each partner supporting their provinces, we jointly funded these annual coverage survey, and now they target, we have a 90,000 sample of kids that are surveyed every year, so that we know where the zero-dose kids are, we know where we have to improve coverage. Beyond the Mashako plan and the programmatic support, we know that in order to sustain the improvements, we need also political commitments and financial support and domestic resource mobilization. And as Dr. Sikomola mentioned, the president organized this forum for immunization and polio eradication, where he invited all the governors, but also all the leaders of all the organizations, so WHO, UNICEF, Gavi, the Gates Foundation, the World Bank, USAID, FCDO, but also the implementation partner, PATH, GSI, Village Reach, the civil society organizations as well. All were joined together under these commitments, which were very specific in terms of what they would do. Dr. Sikomola mentioned the increase in funding from the national government, but for the first time as well, there was a commitment for provincial government to support operational activities, and there was a target to fund $1 per child for each of the provinces to fully immunize the kids. While that was a first step to basically improve domestic resource mobilization. And the Gates Foundation has been working with 3 of these provinces to implement an innovative model for funding, where we would put money in a basket fund between the provincial government and the Gates Foundation, where in the first years we would put most of the funding required to run the operational and the service delivery aspects, but over time the technical assistance and the financial resource would decrease, but would be replaced by the provincial government. And now we have already 4 provinces that have actually exceeded the target that was set up by the president, and some of them contribute up to $4 per child for immunization activities. And we are discussing with other partners such as Gavi and USAID how we can expand the model. So all the efforts that we're doing them jointly with our partners that are here, and we're very happy to continue support. And I think we saw a slide in the beginning on child mortality. I think with the Mashako plan and this initiative, DRC will exceed, hopefully, this target and will reduce more than what is expected. Thank you.
Thank you very much. So we've heard a lot from the 2 panels. Some things I've drawn from the 2 panels is that for vaccine introductions to be successful, they have to be government-led, community-owned, with strong partnership. So now I'm going to call on, so thank you very much. You can take your leave from the stage. I'm going to call on 2.
Thank you. Thank you.
So I'm going to call on 2 very key, strong partners that drive vaccines globally. Dr. Tokumbo Oshe, who is the Director of High Impact Countries at Gavi, the Alliance, and Dr. Ephraim Lemango, who is the Chief of Health at UNICEF. I'll take my leave. Thank you.
Thank you, Andy, and good morning, colleagues. Thanks to the two panels that have given us very great insights about their commitment to introduce PCV or to scale up coverage. I think I heard about operational realities, competing priorities, commitments, and hard work. And I also heard Gavi being mentioned several times. So why Gavi? 14 years ago, Gavi began to support PCV introductions in countries. And since then, we've seen very outstanding results. So 61 country introductions, reaching about 316 million children, averting almost 940,000 deaths across Gavi countries. I think for Gavi, reaching the last child anywhere in the world is foundation to our approach to equity, which is why today Gavi is here to reaffirm our commitment to supporting what we call our last mile countries who are keen to introduce PCV. That is Chad, Guinea, Somalia, and South Sudan. Also, I think we continue to support countries that are willing to scale up coverage, which is India, DRC, Indonesia, and work with our partners to address what we see as challenges across systems to really ensure that PCV can be scaled up as quickly as possible. But to be much more concrete, I think Gavi is here to make 4 commitments. One is to our former Gavi eligible and what we call never Gavi countries. We commit to providing assistance, technical support, financing to really ensure that they can scale up PCV equitably and more sustainably. Number 2, I heard my colleague from Indonesia, Gavi would work with partners, with countries, with private sector to ensure that we can have access to much more affordable vaccines. We can raise awareness about options that are available to countries, so countries can benefit from much more better pricing. Number 3, Gavi will work with partners and civil society to build political will in countries and to ensure that countries prioritize pneumonia-fighting vaccines as priorities for scaling up, based on their context. And I think the most important announcement I will make today is concerning the request we've had for co-financing waivers. So I think for Gavi, we are committed to considering annual co-financing waivers to PCV introductions in what we call exceptional circumstances. So basically, our board recently decided to consider these waivers, temporary waivers, but would expect it to be for countries that have gone through conflict or further situations or crises for at least 4 consecutive years. And basically, that there's been a barrier to the access to pay co-financing obligations. This would have to be part of a request made to Gavi at the point of application for PCV application. So far, based on our criteria, 4 countries are eligible for these waivers. That is Afghanistan, South Sudan, Somalia, and Yemen. So I think for Somalia and South Sudan, we look forward to receiving application with a request for co-financing waivers. Thank you.
And at this point, we're actually going
Distinguished
to have
guests
a
of the
video
second
from
Global Forum
Dr.
on
Lemango.
Childhood Pneumonia, country delegates. Distinguished guests of the second Global Forum on Childhood Pneumonia, country delegates, ladies and gentlemen, greetings to you all. It's a pleasure for me to join this important moment for child survival as we all come together to show our commitment to protect every child from pneumonia. I'm sorry I'm not there with you today in person. It's a World Immunization Week, and just a few days ago, UNICEF launched its flagship publication, State of the World Children Report. The 2023 edition is the first edition of the report solely dedicated to routine immunization. It examines what needs to happen to ensure what every child, everywhere, is protected against vaccine-preventable diseases, including equitable access to all pneumonia-fighting vaccines. I invite you all to read it, share it, and act on it. UNICEF is committed to working with governments and partners, particularly the countries who took part in the previous 2 panels, to introduce and scale up access to all essential vaccines, including pneumococcal vaccines. As you are aware, 2021 vaccination coverage was a red alert for child health, with the largest backsliding in childhood vaccination, eroding 15 years of hard-earned gains. 67 million children have missed 1 or more routine vaccines between 2019 and 2021. UNICEF, WHO, Gavi, and partners are supporting countries to intensify efforts to urgently catch up before it is too late. Countries are taking measures, and we are seeing some signs of recovery in 2022. 2021 also saw declines in life-saving PCV vaccines in 46 countries, something that I find deeply concerning. We need to act, commit, and deliver now. UNICEF will continue to provide the required support to enable countries successfully introduce and scale new vaccines. We do this through strengthening primary healthcare, mobilizing UNICEF's multi-sectoral capacity, partnering with governments and civil society organizations, and deploying our immunization expertise. We recognize that among the vaccines that are essential for pneumonia control, scaling up PCV is a priority, particularly in remaining countries with high pneumonia disease burden. Securing sustainable financing for introduction is one key step. I am encouraged by the ongoing political commitments from the governments of Chad, Guinea, Somalia, and South Sudan to introduce PCV in routine immunization, and commend Indonesia and India for their work to take PCV to scale. UNICEF will work to ensure access to the pneumonia-fighting vaccines for all children through political engagement, resource mobilization, and providing technical assistance in demand generation and supply chain strengthening. As the world's largest volume vaccine supplier, we'll continue to diversify product choices to ultimately lower cost of pneumonia-fighting vaccines, including pneumococcal vaccine. We'll also explore opportunities within the Gavi Alliance, as a member of the Gavi Alliance, for funding flexibility that can help countries in fragile settings introduce new vaccines. I would like to thank all of you for your remarkable efforts to end preventable child deaths from pneumonia, and reiterate our commitment to support countries to achieve equitable access of all vaccines for every child.
And so before we go to our next panel, very strong thank you to both Dr. Ade and Dr. Ephraim from Gavi and from UNICEF. From this morning, listening in, thinking of Dr. Ende's words about government-led, community-owned, strong partnership. The governments made clear what they felt they needed from some of the partnerships. It is really encouraging to hear some of the partners responding to those strong requests. So I think it's an indication that some of the advocacy is working. So we need to keep with the advocacy, as well as keeping with the other methodologies that we're using for this vaccine introductions. And now the next panel is going to be discussing new approaches to reaching zero-dose children in humanitarian settings, which we know is a real challenge on many, many fronts. And the person who will be moderating and leading this discussion, Dr. Chizoba Wonodi. Please join us on stage.
Thank you. Good morning, ladies and gentlemen. Welcome to this panel on zero dose. You've been hearing a lot about zero dose in this meeting. Zero-dose children are those who have not received any vaccination from the routine immunization program. And we know that vaccines save lives, save money, enable children to attain their full potential. Therefore, children who are denied vaccines are denied a lot in life. In 2021, UNICEF and WHO estimated that there were 18 million zero-dose children. We heard Dr. Ephraim talk about the backsliding related to the COVID pandemic. And when you look at the IA 2030 goal of reducing zero-dose children by 50% to 6.6 million in 2030, you see that we're off track as a global community. In fact, we're not just off track, we're moving in the wrong direction. Therefore, it's really important to do something about the zero-dose problem. But this issue does not affect every country equally. 2/3 of the zero-dose children in the world live in 5 countries: India, Nigeria, the DRC, Pakistan, and Ethiopia. A further 18% live in 16 fragile countries. These countries that I mentioned, we hear them in several lists, appearing over and over again. Sometimes it's because, to a large part, it's because of their large population, but also to another instance, it's because of the low health indices in these countries. So, to act on zero-dose, to address zero-dose, we must really focus on the settings where majority of zero-dose children are found. And these are in urban poor areas, remote rural communities, and in conflict settings. That's the concentration of zero-dose children. That doesn't mean that you can't find them anywhere else. The WHO, the Gavi, and the global immunization leaders have made addressing zero-dose, the challenge of zero-dose, a priority in order to address equity and ensure that no child is left behind. There are strong, pragmatic, moral, and developmental reasons why we must prioritize zero-dose children. We know that zero-dose children live in communities that are deprived of several other social amenities. You could say that zero-dose children live in communities that are zero-dose for water and sanitation, zero-dose for health services, zero-dose for financial services, you name it. The data has actually shown that a lack of immunization has been associated with lack of maternal education, lack of sanitation, lack of bed nets, and even acute malnutrition. So if we use the zero-dose programming to address primary healthcare issues, we will really be addressing multiple health deprivations at the same time. Think about it. We've been talking about the power of pneumonia fighting vaccines. That zero-dose child that is denied of PCV vaccine is more likely to get pneumonia and be acutely sick from pneumonia. If the child is taken to the clinic near them, that clinic is also likely to be zero-dose for oxygen, and their parents are likely to not have money to treat the child. So what happens is a catastrophic cascade of events that may eventually lead to her death. So we cannot emphasize enough the importance of identifying the zero-dose children, reaching them with services, and then advocating for them to our governments, to our partners, to dedicate the resources and the financing that is necessary to reach and address them. So in Nigeria, where you have 2.2 million zero-dose children, the government and partners are unveiling new approaches to try to address this problem. There is the Z-Drop tool that has been designed, that's called the Zero Dose Operational Plan tool, that is helping subnational immunization managers at the local government level and at the facility level really pinpoint which communities actually house the biggest burden of zero-dose children among the 100 prioritized local government areas that the country has identified as, having the biggest challenge of zero dose. And the key here with using the Z-Drop tool is really to work with the community leaders, with the community members, to identify the package of integrated interventions that will be delivered. So for a health facility manager, they would work with their community leaders to see if it's vaccines and nets that need to be delivered, or vaccines and nutritional supplements that need to be delivered, and where would this be delivered? Would it be in the community center? Would it be in the market? Will it be in the mosque or in the church premises? When will it be delivered? When is the best time to reach the most children? Is it in the morning or in the evening? What day would be best for them? Is it during the week or in the weekends? So this tool allows them to bring in the flexibility that's needed to serve the community in very specific ways. So it's very clear we cannot solve the zero-dose problem by working alone. Government cannot do it alone. We need partners. We need civil society organizations, as we've heard. We need even people who are not within the health sector, educational sector, people who work in agriculture, who work in water and sanitation. In this panel today, you're going to hear about Gavi's recent investment, $100 million investment in the ZIP project, which is a collaboration between Gavi and civil society organizations to reach millions of children in fragile parts of the Sahel and Horn of Africa. So first of all, to kick off the discussion, it's my pleasure and privilege to introduce Mr. Shefe Demise. He's the project director, Gavi Reach, Horn of Africa. Mr. Shefe.
Thank you so much for the wonderful introduction and background, Dr. Chizoba. Good morning, everyone. I'm so excited to talk about the Gavi Reach project. Reach stands for reaching every child in humanitarian setting. The goal of the project is to reach zero-dose children in mixed communities in conflict, fragile, and cross-border settings beyond the reach of the state or the health system. We have three, key components to achieve the goal. The first one is identification of locations with large number of zero-dose children, identify the key barriers for immunization, and describe the characteristics of the communities that they live in. The second one is, once we identify the zero-dose children, is to reach them with immunization services. This involves humanitarian access negotiation, addressing the key barriers we have identified in relation to demand, supply, gender-related constraints, and the likes. And finally, the third one is to monitor, manage, and learn from the project. To do this, we have established a consortium of global partners that bring complementary responsibilities and expertise. International Rescue Committee, or IRC, is the lead of the project. Think Place brings human-centered design approach to the project. Flowminder is responsible for geospatial mapping, and using that, we will know how the children are distributed against publicly available facilities. A core group is responsible for high-level communication, advocacy, and coordination of learning from this project and Raise for Sahel that's implemented in the Sahel region of Africa. And IM is responsible for cross-sector health initiative and displacement tracking matrix. They are also in charge of direct service delivery in some of the locations, including cross-border settings. We also have a network of local civil society organizations across the 4 countries in Horn of Africa: Ethiopia, Somalia, Sudan, and South Sudan. And the key responsibility of the CSOs is to revitalize the community-based structures, negotiate humanitarian access. Some of them already have pre-existing negotiated access to some of the most difficult places, and deliver immunization services to zero-dose children in the target locations. Of course, we work very closely with the Ministry of Health at all levels of the health system in each of the country, and also with other partners, including UNICEF, WHO, and other key partners that play a key role in immunization programming. During the identification stage of the project, which is during the inception period, we identified around 5.3 zero-dose and under-immunized children. This is under 5. I'm emphasizing the under 5 because I will come back to it at a later stage. We also identified 124 districts with large number of zero-dose and under-immunized children. On the map, you will see that the dark locations are, the dark shaded areas are the locations we have identified for the project. By the time we did the identification, more than 80% of the locations are considered to be conflict setting. Close to 40% of them host nomadic population that move across the international borders within, the Horn of Africa. They also 60% host IDPs. It was only around 41% that were under the full control of the states. The rest of the locations are either only partially controlled by the states or outside of the state control. They are controlled by non-state actors. This was as of December last year, and a lot has changed over the last several months. For example, the agreement between TPLF and Ethiopian government has resulted in peaceful resolution, and some of the locations have become they are under the control of the government right now. So when we completed the inception period and we started to reach the children, we decided to do that in phases because we work in conflict and fragile setting, and safety and security is a huge concern. We decided to start in locations where we have a good access, and that's phase 1 location, and that's green. Orange locations are locations where we have only partial access and requires humanitarian access negotiation with various actors. Red locations are locations where there is active conflict, and therefore it requires high level access negotiation or waiting for humanitarian truce to be established. And we kept on monitoring the changes in humanitarian setting and in access. And as you can see, from December to March, the color is changing. There's rapid change in humanitarian context across the Horn of Africa, as can be seen on the map. When we look at the distribution of zero-dose children, for example, in Sudan, at least 80% of zero-dose children are located at further than 15 kilometers from the nearest health facility. This is irrespective of whether the facilities are functional or not. And this tells us, how we can, deliver approaches. For example, static kind of service delivery is not going to be applicable in such context. On the other hand, in Somalia, if we take Baidoa, for example, the zero-dose children are concentrated in, small radius of area. This is mainly because there is a huge influx of IDP, including from deep locations controlled by Al-Shabaab. And the children that come with those IDPs are all zero-dose children. They are never vaccinated. And since they are so concentrated, our delivery model would be different from a setting that we saw as an example in Sudan. So when we look at our delivery approaches, we tailor our approaches to the context. We do not have a one kind of approach. It varies from context to context, and is tailored. We are also planning to introduce innovative cold chain equipments, such as Indigo backpacks, which, if charged once, it can last for up to 5 days or even beyond. And that would allow us to go to far places that we cannot do with the conventional cold chain equipment. We also use the IAM displacement tracking matrix and the Flowminder geospatial mapping to optimally locate our service delivery points to ensure that we get the maximum number of zero dose and under-immunized children. Program integration is a key thing. We are going to very difficult locations. We are actually extending immunization services of the health system in each of the country. So we require to extend other services because we are going to communities with multiple deprivations. And we have some examples already with integration, but because of time, I'm not going to get into that. Innovative ethnographic approach, including human-centered design, is one of our approaches. Humanitarian access and access negotiation is a key component given the setting. And we use a robust data management system that would allow us to flow data from our service delivery points into the Ministry of Health's data management system, and also through our own data management system, which is based on Concur and Power BI. Evidence generation is a huge undertaking on the project, and we look forward to sharing learning from the project over the following months and years. When we look at the early data, we started service delivery recently, and so far we have vaccinated around 38,000 children with DPT1 and around 26,000 with Penta3 or DPT3. I would like to pause for a minute on this one. The children that are vaccinated for Penta1 or DPT1 are mostly under 1. The reason for that is mainly due to access to vaccine. Earlier, I have indicated that the zero-dose children we identified are under 5, because we are looking at older children than what the guidelines and strategies of the Ministry of Health allows, because we are going to communities that are missed out for years. They are chronically missed out. And older children are also unvaccinated. And that's why we identified all of the children that are under 5 that are zero dose or under immunized. However, when we go to the ground, we have to rely on the existing policy and strategies, which limits vaccinating children only up to 1 year or 2 years maximum. The policies do not allow to go beyond that. We have been negotiating with the Ministry of Health of all the 4 countries, and they're okay, they're convinced. They see, vaccinating older children in such context is reasonable, but they are faced with resources challenges, because the vaccine stock they have is based on the guidelines that they have. And because of that, it's not easy for us to vaccinate all the zero-dose children that are beyond the policy, because the vaccine is not just enough. We have been discussing this. The discussion is still ongoing. We are discussing with Gavi also to find a solution to this. And I hope that it will be resolved. Otherwise, it will be a huge missed opportunity when we go to such difficult context and we are not able to deliver services. If vaccine is available, we can deliver it at no additional cost to the project. Moving forward, so we intend to intensify service delivery. Like I said, we just started, and we plan to ensure that we reach all of the green locations and the orange locations over the following months. We will engage, the consortium members, including IRC, the governments, donors, and other stakeholders, to extend other, social services to the community that are left out, using the REACH project as an entry point. We will amplify learning from this project, and we look forward to sharing what we learned from the project. We need to, generate learning on how, INGO or civil society-led immunization program can contribute to, increasing equity to the work that the Ministry of Health does. Of course, influencing the national strategies and the policies is critical. Like I said, the strategies and the policies which are adopted long ago are not addressing the unique needs of zero-dose children. And the zero-dose concept is relatively new. It's just started, and there is a need to revise and accommodate the unique needs of these communities. Thank you so much.
So it's my pleasure to introduce Dr. Omar Diallo, Secretary, Deputy Director, Race for Sahel, World Vision US. Dr. Diallo.
Ok, merci. Buenos días a todo el mundo. Bonjour à tout le monde. Je suis Dr. Omar Diallo. Je suis le directeur adjoint du secrétariat Race for Sahel, World Vision Mali. Donc, j'ai le plaisir et le privilège de vous présenter les stratégies pour atteindre les enfants 0-12 et les sous-immunisés au Mali. Donc, avant tout, nous allons vous faire un aperçu général du projet Rise for Sahel. Donc, le projet Rise for Sahel, c'est un projet qui s'étend sur 5 ans, de 2021 à 2025. C'est un projet multi-pays, comme on l'a dit. Il couvre 7 pays, notamment le Mali, le Burkina, le Cameroun, la Centrafrique, le Nigeria, le Tchad. Donc, l'objectif général, le financement, c'est Gavi, à peu près 60 millions de dollars. Et l'objectif principal, c'est vraiment d'offrir durablement des services de vaccination de qualité aux enfants n'ayant reçu aucune dose de vaccin, c'est-à-dire les 0 doses, et les enfants insuffisamment vaccinés, c'est-à-dire les sous-immunisés. Donc, le projet est géré par World Vision US en consortium avec ses partenaires comme Food for Hungry, qui s'occupe du volet genre, équité et inclusion sociale, Core Group qui s'occupe du volet communication et d'Imagie qui s'occupe de tout ce qui est technologie et gestion des données. Donc, au total, dans les 7 pays, nous avons 27 régions et 90 districts. Donc, nous devons atteindre environ 386 106 enfants 0 dose et 585 000 enfants sous-vaccinés. Donc, l'accent va être mis sur l'inégalité entre les sexes, l'apprentissage dans les pays et les régions. Quelles sont les caractéristiques principales des communautés manquées? Parce que nous agissons au niveau des communautés manquées. Donc, d'abord, ce sont des zones de conflit. Donc, il y a les conflits armés qui constituent la caractéristique prédominante des communautés manquées. Le climat, c'est des zones défavorisées sur le plan climatique également. Nous avons les sécheresses et les inondations qui entraînent souvent la perte des récoltes, d'où la mobilité des populations. Ce sont des populations qui sont très mobiles. On sait, suite aux conflits armés, il y a beaucoup de déplacés internes qui sont hébergés dans les camps. Nous avons des réfugiés, nous avons des populations transfrontalières et nous avons des communautés nomades aussi qui sont très mobiles également. Nous avons des agro-pastoralistes et il y a la migration forcée également. Alors, quel est le contexte opérationnel au Mali? Nous savons que le Mali traverse une crise sécuritaire depuis 2012. Donc, la crise sécuritaire, elle est permanente. Il y a les conflits armés, il y a les groupes religieux extrémistes, il y a les communautés dispersées et difficiles d'accès. En ce qui concerne les centres de santé, il y a une accessibilité en raison de longue distance, c'est-à-dire l'inaccessibilité géographique, à pouvoir parcourir et arriver à certaines populations. Il y a aussi l'insécurité qui couvre les 2/3 du pays. Il y a les contraintes financières. Souvent, les populations ont la volonté de venir faire vacciner les enfants, mais il y a les contraintes financières, c'est-à-dire il faut, pour le transport, il faut des moyens, il faut payer le transport, il faut emprunter, que ce soit un moyen de déplacement public ou si c'est privé, il faut mettre le carburant. Donc souvent, il y a la barrière financière qui est là. Il y a le problème d'équipement et de chaîne de froid aussi qui est là. Par rapport à la demande, il y a un certain nombre d'obstacles aussi. Nous avons même eu à mener une enquête CAP et obstacles à la vaccination. Et nous avons relevé un certain nombre de barrières par rapport à la vaccination. Il y a notamment une insuffisance d'information et de sensibilisation en matière de vaccination. Il y a les séances de vaccination qui ne tiennent pas compte de la disponibilité des femmes. Souvent, les gens viennent, mais les femmes ne sont pas disponibles. Donc, depuis la micro-planification, c'est pourquoi il est important de faire la micro-planification au niveau communautaire pour pouvoir prendre en compte les préoccupations des populations, pour pouvoir planifier les séances de vaccination en fonction de la disponibilité des mères d'enfants. Donc, il faut voir à quel moment ils sont disponibles et planifier les séances de vaccination pour faciliter la présence des femmes pour la vaccination. Au Mali, Rise for Sahel intervient dans 3 districts et dans 7 districts à travers 3 régions. Dans la région de Tombouctou, nous intervenons à Diré. Dans la région de Ségou, nous intervenons à Tomignan. Et dans la région de Mopti, nous avons 5 districts sanitaires. Le district de Mopti, le district de Bandiagara, Youarou, Koro et Bankas. Donc, ces districts ont été sélectionnés en collaboration avec le ministère de la Santé, bien sûr, et les partenaires comme Gavi, l'OMS et l'UNICEF. Donc, nous avons des stratégies opérationnelles pour pouvoir intervenir. Donc, les zones où il y a le conflit permanent, par exemple, nous avons comme stratégie opérationnelle la sensibilisation, les centres fixes, les centres de vaccination en centre fixe, les équipes mobiles, l'intensification des stratégies avancées, la vaccination d'entrée et de sortie, c'est-à-dire les zones où vraiment il y a le feu, là où la situation sécuritaire est vraiment très difficile, très précaire. Donc là, il s'agit d'intervenir rapidement et de partir. Il y a aussi la vaccination avant de déplacer les populations. Donc, dans certaines circonstances aussi, les services médicaux se déplacent vers les populations déplacées. Donc, là où il y a aussi le conflit actif, nous avons aussi des stratégies opérationnelles. Nous avons, par exemple, les zones rouges. Ça, il faut une négociation avec les maîtres des lieux, c'est-à-dire les groupes radicaux qui sont sur place. Il faut forcément négocier avec eux pour pouvoir avoir accès aux populations pour vacciner. Aussi, il y a là où il y a les catastrophes, les inondations, et là on fait les séances de vaccination en centre fixe, la sensibilisation, les équipes mobiles et aussi les campagnes d'intensification en stratégie avancée. Okay. Au niveau des camps d'hébergement des déplacés internes, là, il faut faire aussi il faut faire comme les communautés d'accueil. Si c'est dans certaines zones, par exemple, les gens optent pour accueillir les déplacés dans les familles au lieu d'aller dans les camps. Au Mali, par exemple, à Koro, c'est cette stratégie qui est adoptée. On ne fait pas de camp, mais les habitants même accueillent les déplacés dans les familles. Dans ce cas, on adapte la stratégie en fonction de ce qui se fait dans les familles d'accueil. Aussi, les migrations forcées. Là, c'est les équipes mobiles, c'est la sensibilisation et c'est l'intensification des activités de vaccination. Et par rapport aux réfugiés aussi, c'est la stratégie fixe, c'est les actions de... c'est aussi la vaccination à l'entrée, la vaccination dans les zones d'atténuation et puis aussi l'intensification des campagnes de vaccination. Les zones nomades aussi, on fait la sensibilisation, on fait les équipes mobiles, on fait la vaccination au niveau des frontières et aussi l'intensification des activités de vaccination de façon temporaire. Nous savons que nous avons des zones frontalières, il y a des districts frontaliers avec le Burkina. Donc, nous travaillons avec l'équipe Reste for Sahel du Burkina pour organiser des séances de vaccination conjointes au niveau des frontières et également des rencontres périodiques pour pouvoir faire l'analyse des données par rapport aux 0,12 et les sous-vaccinés. Donc, qu'est-ce que nous devons faire pour renforcer la prestation de services au niveau des services de vaccination? Il s'agit d'augmenter la disponibilité de prestataires de services formés. On sait qu'il y a une insuffisance d'agents vaccinataires. Nous avons fait une évaluation dans nos districts d'intervention. Nous avons besoin de recruter 35 agents vaccinataires. Nous allons les recruter et les prendre en charge. Il s'agit de motiver les prestataires de services. On sait que les agents de vaccinataires, ce n'est pas des fonctionnaires, c'est des agents qui sont recrutés localement par les collectivités ou les ASACO. Et il y a très souvent des arriérés de salaire, des indemnités, même pas salaire, mais des indemnités 6 mois d'arriérés. Donc, cela ne les motive pas. Quelqu'un qui n'est pas motivé ne peut pas faire du bon travail. Donc, nous allons quand même prendre ceux que nous allons recruter, nous allons les prendre en charge, leur motivation également. Il s'agit d'atténuer aussi les perturbations, les perturbations liées au vaccin, c'est-à-dire les ruptures de vaccins dans toute la chaîne d'approvisionnement. Aussi, nous avons des approches innovantes, c'est-à-dire les indigos, il en a déjà parlé, les porte-vaccins qui peuvent conserver pendant des jours. Le mentorat et la supervision, le soutien, impliquer et élargir aussi le rôle des OSC, les organisations de la société civile et les organisations confessionnelles. Nous allons travailler avec la FENASCOM et la PPF dans ce cadre-là, pour nous accompagner et pour pouvoir atteindre les cibles. Nous allons nous attaquer aussi aux obstacles liés à l'accès, c'est-à-dire le sexe, le handicap et les tabous. Nous allons aussi négocier avec les partenaires des Nations Unies comme OCHA. Et nous allons tirer parti des interventions existantes de World Vision qui existe déjà, c'est-à-dire l'intégration des interventions. Déjà, World Vision a un certain nombre d'activités, un certain nombre de domaines d'intervention. Donc, nous allons faire une intégration, c'est-à-dire nous allons coupler la vaccination avec les distributions alimentaires, le transfert cash, avec le WASH et toutes les autres interventions possibles. Donc, comme approche d'intervention, nous agissons comme les feux tricolores. Nous savons qu'il y a des zones vertes, il y a des zones oranges et les zones rouges. Les zones vertes, ce sont les zones où l'accès est vraiment beaucoup plus facile. Donc, nous allons commencer par intervenir dans ces zones-là. Au Mali, les zones vertes, c'est Mopti et Tomignan. Bien qu'il y a eu des événements récemment qui peuvent faire évoluer les choses au niveau du district sanitaire de Mopti. Donc, les zones oranges, nous avons aussi certains Yuaru, Korobankas, Et zone rouge, nous avons Diré. Là, c'est vraiment très difficile parce qu'il y a une grande partie qui est sous contrôle des groupes radicaux. Là-bas, la situation, il faut négocier vraiment avec eux. Là-bas, même pour la vaccination, un homme et une femme ne peuvent même pas aller sur la même moto. On sait que pour aller en stratégie avancée, le vaccinateur il va avec la matrone pour pouvoir offrir aussi la CPN et la vaccination ensemble. Mais là-bas, cela n'est pas possible. Parce qu'ils disent, si ce n'est pas ta femme, tu ne peux pas être sur la même moto qu'un autre homme. Donc, il y a beaucoup de problèmes, de difficultés liées au contexte. Donc, on essaie de voir comment il faut gérer cas par cas selon la zone d'intervention. Il y a des zones où on ne peut pas aussi utiliser les motos. Il faut utiliser les katakatani ou c'est séparer l'homme et la femme. Donc, tous ces aspects-là, nous allons les prendre en compte pour pouvoir vraiment agir de façon efficace et efficiente et pouvoir atteindre les objectifs qui est de vacciner les enfants 0-12 et les sous-vaccinés. Donc, pour assurer l'assurance qualité, nous allons avoir des examens mensuels, des rencontres mensuelles et trimestrielles pour faire l'analyse des données. Nous avons des réunions mensuelles avec les responsables nationaux Gavi et les gens qui appuient les pays qui sont au niveau de Genève également. Et nous avons la supervision de la haute direction de World Vision US et le bureau régional de World Vision pour l'Afrique de l'Ouest aussi. Nous faisons aussi le suivi semestriel des données PEV, on fait le monitorage. Et aussi, nous avons des visites régulières de supervision du PEV et nous avons des appels hebdomadaires. Donc, grâce à Race for Sahel, les services de vaccination seront plus accessibles dans les zones fragiles et touchées par les conflits dans l'ensemble du Sahel. Donc, tout au long du programme Race for Sahel, les nouvelles innovations et les enseignements tirés seront documentés et diffusés afin d'améliorer non seulement la programmation actuelle, mais aussi les planifications futures. C'est un nouveau projet, donc c'est un nouveau projet partout, donc il y a beaucoup de choses à apprendre. Donc il faut que nous documentions que ce soit les succès, mais aussi les difficultés, les défis, pour que nous puissions améliorer les choses dans le futur. Donc, voilà un peu ce que nous avons en ce qui concerne World Vision à travers le projet Race for Sahel. Je vous remercie.
Thank you very much, Dr. Diallo and Dr. Demisi. So, ladies and gentlemen, you have heard it from both gentlemen about the interesting work that Gavi is funding in these fragile settings. I'm really looking forward to the next 5 years when this project will end, all the lessons that have been learned, and then also the zero-dose children that would have been vaccinated. 2030 is just 7 years away. The goal is to reduce the number of zero-dose children to 6.6 million from 18 million. In order to do that, we have to really redouble our efforts to identify the zero-dose children where they are, reach them, even if they are hard to reach or dangerous to reach, convince them to get vaccinated or their parents for them to be vaccinated, even if they are difficult to vaccinate. And then us as an immunization community, civil society organizations, we have to continue to raise a voice for addressing zero-dose, because zero-dose children are not low-hanging fruits. It will take much more to vaccinate zero-dose children, children who are chronically zero-dose than other types of children. So we need to keep up the political pressure, the financial support, and also ensure that the zero-dose agenda is is leading the charge for integrated services. So as you go with vaccines, you go with other services. And then we address the multiple deprivations these children and their households and communities face. Thank you very much and have a wonderful day.
Thank you very much to that panel. A really important topic. We're now actually going to take a little break. We're running a little bit late, so I'm going to ask you if you could all be back by 11:20. While you're on your break, coffee served in the foyer the way it was yesterday. Please remember to sign the declaration on the wall if you haven't done that already. And we'll see you back here 11:20 in your seats, please, okay? Thank you. Who are still standing to find your seats as quickly as possible. We've got a really interesting panel just waiting behind there for everyone to be seated. So, great. Okay, so we're going to jump straight in. We've got a wonderful panel, actually. We've been talking about new vaccines. We've been talking about outreach of old ones. This is a panel that's going to be looking at strategies for making vaccines more accessible and affordable. And please help me welcome to the stage the moderator for the panel, Dr. Raji Tajuddin.
Right. Good morning, colleagues, ladies and gentlemen. Let me, on behalf of my panelists, welcome you to this important session that will be looking at making vaccines accessible and affordable. What are the effective strategies that is required to expand coverage? Colleagues, we learned so many lessons from the COVID-19 pandemic. Also, we saw so many challenges. And one of the key and critical challenges as far as the COVID-19 pandemic is concerned is that of vaccine equity. We saw the way some countries in low and middle income countries had to rely on goodwill from some other country to have access to the COVID-19 vaccine. We also saw the way some countries had to wait at the back of the queue to get access to these vaccines. And we also saw the way some countries had to rely on what trickled down after some countries have enjoyed a fair share of their own vaccine 4 times over. It was in this regard that some countries or some regions developed certain strategies. Okay. And in Africa in particular, we had to leverage our political platform. We had to work with our head of state and government to put in place a strategy that will address our immediate need and our long-term need as far as vaccines in general is concerned. So to join me in unpacking this particular agenda, I have with me Stephen Karingi, who is Director, Regional Integration and Trade Division, United Nations Economic Commission for Africa. I also have Dr. Nelly Zakia, Health Economist, Pajajaran University, Indonesia. Yeah. And we have Mr. Masood Alam, Health Strategic Planning, Commercial Development, Emerging Market, Serum Institute of India. I also have Professor Fiona Russell, Lead Asia Pacific Health Research, Model Children Research Institute, Australia. And last but not the least, we have Miriam Alia, Vaccination and Outbreak Response Advisor, Medicine Sans Frontiers, MSF. Colleagues, ladies and gentlemen, to set us going as far as this session is concerned, I would like to throw my first question to Stephen Karingi. Stephen, the African Union member states, the Africa CDC have developed an ambitious agenda to increase vaccine manufacturing on the continent of Africa. Why is this so important? Over to you, Stephen.
No, thank you very much, Dr. Raj, and good morning, good afternoon, good morning, everyone. So the agenda for the African Union, you've given a good background why this is important. It's basically to ensure that by 2040, Africa is able to produce at least 60% of the vaccines that it consumes. Now, why is this important? First, we know that the population of the African continent is going to double very soon, which means that the demand for vaccines is actually going to be also to double. Beyond that, we also know that there is a transition in diseases that is happening within the continent. And we also know that in order to be able to create health security for this growing population, it's very important that Africa is able to have access to affordable vaccines. So essentially, this strategy for 60% of all the vaccines needed also means that you need to have a situation whereby whatever is produced in the continent, it allows you to have quicker access to the supply chain, because as the moderator has said, we faced a situation whereby it was not possible for Africa to get the medicine, the vaccines when it needed them. So the bottom line of why this strategy is important is, first of all, just to create health security for a growing population within the continent. That health security is important because it is an anchor for economic growth. It's also an anchor for ensuring that lives are not lost the way we saw them being lost during COVID-19. So what does this strategy also entail? It also entails a reshaping of the market within the continent, and also how the supply chain that we know operates today, how it works in the years to come. So for now, I think I would want to make that point.
No, thank you, Stephen, for that submission. So next, I would like to invite Nelly Zakia. As a health economist, how should government be thinking about getting the most out of their vaccination programs, getting the highest impact on child death prevented for the most affordable prices? Over to you, Zakia.
Okay. Thank you very much. From the health economics perspective, I must say that it would be ideal for governments as policymakers to base their decision on evidence when implementing a public health program such as vaccination program. And this includes evidence not only on the effectiveness of the vaccine, because we may already know that the vaccine for several preventable diseases is effective to reduce the burden of the disease itself, but also to consider the cost effectiveness of implementing this program. And it means that government should look into an alternative, maybe comparing two different programs in terms of total cost. And this total cost may include the cost of vaccine itself, the treatment, the intervention itself, and also cost for procurement and cost for supply chain, for example, and the cost of treatment that could be prevented as a result of the vaccination. And comparing it to the health outcomes or effectiveness as a result. So the health outcomes here from the health economic perspective, we can estimate, calculate, evaluate the number, for example, the number of child mortality prevented, or maybe the number of morbidity on mortality averted, and also it is possible to measure the overall societal quality of life. And from that evidence, then government can aim to invest on the program that offer the greatest impact at the most affordable prices. I'm sorry. But sometimes, as we also heard from the previous panel, that the data, that the evidence is not readily available, while the burden is already burden the country. So in that case, it is also possible to take a look at the global data, for example, and country can project from this global data to make an informed decision so that they can make the best out of vaccination program.
Thank you so much, Zakia. Let me invite Masood from Serum Institute of India. You make the most affordable pneumococcal vaccine for children. How are you seeking uptake of this vaccine, especially in low and middle income countries? And what are the expected barriers to the uptake of these pneumococcal vaccines?
Thank you. And good morning, everyone. And thank you to the organizers for inviting Serum Institute of India to provide a perspective of the new, affordable, sustainable pneumococcal conjugate vaccine, which has just come on the horizon about 2 years back. I would like to answer this question in three perspectives. One is to give you a flavor of what Serum Institute of India in the last 5 to 6 decades has demonstrated the affordable access of its 25 WHO pre-qualified vaccine. A pneumococcal conjugate vaccine happens to be the one. So with all humility and humbleness, as a Serum, we are working across all the countries sitting here in a very close collaboration for providing many of the national immunization programs from Penta to measles programs, etc. And therefore, Serum and our chairman, Dr. Cyrus Poonawalla, and our CEO, Mr. Adar Poonawalla, stands very committed for providing many of the upcoming vaccines, including pneumococcal conjugate vaccine on an ongoing basis. Just to give a perspective, the pneumococcal conjugate vaccine is a development of almost about a decade in collaboration with PATH and Gates Foundation, many of the experts sitting here who have been part of the product development, clinical development, leading to WHO pre-qualification. And we got the pre-qualification December 2019, post which we got hit into the COVID pandemic, and the countries were busy with COVID. But what is very exciting that despite countries and we as a company was busy with COVID, the fastest uptake, and with all humility I say, for a pneumococcal conjugate vaccine has been Pneumocell. As on today, when I speak, we're talking of about 100 million doses has been administered already into various countries. And in my opinion, I think it is one of the fastest uptake of a pneumococcal conjugate vaccine. Yet, we have a long way to go to provide a perspective. Just on the cost effectiveness and sustainability of a PCV program, I think I just wanted to put some numbers. 100 million doses being distributed so far means approximately $100 million being unlocked from these countries who have used this vaccine, have used these funding for other programs. In this room, we have about 14 countries. When we look at India, 26 million kids, and the rest 13 countries, we are talking of 26 million kids. So we're talking of 75 to 80 million doses of pneumococcal conjugate vaccine, assuming 100% coverage. And as on today, with the Gavi pricing, if the new affordable and sustainable conjugate vaccine is being used, we are talking of each year about saving of $75 to $80 million being unlocked for the government for using for other programs. And it's not the issue of just 1 year of a cohort being vaccinated. These programs need to run on a sustainable basis. So if you're talking of 5-year program to run for a program, you're talking of almost about $500 million being unlocked. So I think this is a very important perspective to look at when you have a WHO pre-qualified vaccine, is being pre-qualified, keeping the same consideration as the way the other WHO pre-qualified vaccine has been done, is of a good quality vaccine, certified, and can get into the most of the national immunization programs, sustainable clinical programs, and the data is available. what is very important for us is to get engaged with the countries to get the perspective there. There have been some barriers, and this is very clear that when a new vaccine comes on the horizon, the market doesn't like to break the equilibrium. So the status quo is, the market tries to maintain the status quo, and important is to bring a right information for a decision maker in the country, for a right stakeholder to take an appropriate decision that whether this vaccine will help in terms of in running the PCV program in a sustainable manner. And we're very happy to actually engage and collaborate on that.
Thank you so much, Masood. We know that you guys are the world largest producers of vaccines, so really thank you for that. Now, let's move to Fiona. You've worked very successfully with several Asia-Pacific countries to strengthen their vaccine programs, including the introduction of pneumococcal vaccine, rotavirus, and human papillomavirus vaccines at the same time, and by switching to more affordable vaccines, which means more children can be vaccinated. Can you describe some of those examples, and can you also share your experience as far as this introduction is concerned?
Thank you very much, and I'd just like to also thank the organisers for inviting me to this very important panel. So about 20 years ago, we started research in partnership with the Fiji government on pneumococcal conjugate vaccine, and at the time it was the 7-valent, which was specifically designed for the US market, and it wasn't designed for low and middle income countries because it didn't contain the most important serotypes. So at that time we did clinical trials to try and identify how many doses of vaccine you actually really need. And in addition to that, we looked at the burden of disease for pneumo as well as rota, which came out about the same time, and also HPV vaccines, and so with the government's request. And so based on all of those results, the government was very keen to introduce, but being a middle-income country at the time, there weren't any sort of options, and this is a very small country, a small country in the Pacific. We then advocated with our government, PFAT, to help support Fiji. And so what they did was they took on the role of like Gavi, where they did a cost-sharing arrangement over a number of years, and after the 4th year, the government introduced or paid for all the vaccines. So this is the 3 vaccines introduced pretty much at the same time. And so initially, and that has been ongoing and sort of sustainable. Now the Fiji government for the last 7 years has been fully paying for the vaccine. This then inspired many of the other Pacific Island countries to then introduce vaccines as well. And so the Asia Development Bank and UNICEF then supported 4 more countries to introduce, and then the Rotary International, both Australian and New Zealand International branch, fundraised for the first time to then get enough support for 5 other countries in the Pacific. Again, very small countries, but to introduce all 3 vaccines pretty much at the same time. And this was during COVID as well. So the Pacific, closed all their borders and pretty much mostly were spared the worst of the pandemic until vaccine came along. So they were able to do that and did that very successfully. And so now, similarly, we help support the design of that program. And so over 5 years, the governments had year by year an incremental increase in the amount that they would be paying for the vaccine themselves. So by the end of the 5 years, they would be fully paying for it. So then they introduced the PCV13, however, so now we're advocating for them to use Pneumocil. Fiji switched over to Pneumocil a couple of years ago, saved hundreds of thousands of dollars. Again, a very small country, but that's a lot of money for them. So hopefully they're a bit of a trendsetter for the Pacific, so hopefully that will happen there as well. Now, in terms of things I've learned, many things I've learned, but there's 3 things particularly I'd like to sort of say. One is about the schedule and how many doses do you really actually need? And so it's really important to be critical and think about, well, how many doses are really needed? And we're doing that for COVID at the moment. And really this need of, 4 doses, which is used in the US, 3 doses for WHO, but, there's clinical trials now showing that 2 doses is enough. And so UK has moved over to that a few years ago. The pandemic has, affected the epidemiology, so we don't quite know the impact of that as yet, so we're waiting to see. But clinical trials both from South Africa and Vietnam have just been released recently that show 2 doses are equivalent, more or less, on vaccine-type carriage as 3 doses of vaccine. And that's using the 13-valent vaccine and the GSK 10-valent vaccine. The Gambia has got a cluster trial that is using 3 doses as well, and the impact of those results will be out next year. The second thing is vaccine price, and this is what the governments look at. So, as we've heard, many countries look at cost effectiveness analysis, and by and large, most of them show the vaccine is cost effective, but it's the budget impact that the Ministry of Finance looks at. And that's the thing that the Ministry looks at up front, and their eyes roll and start to water. And that's a huge issue, is the cost to roll out a new program. And that's really where partners can help and help support countries, is help them with those startup and rollout plan. And the third issue is middle-income countries. So they've really been left behind. 70% of the world's poor live in middle-income countries. So if you don't have the purchasing power of a large economy to be able to then, haggle with pharmaceutical companies, then essentially it's more or less, bad luck.
All right. No, thank you so much, Miriam, for that. High-level, summary from your experience from the Asian Pacific region. And I want to believe that some of this experience can be replicated in other low and middle-income countries. So I know that we have around 10 minutes or so remaining. So maybe quickly, let me go back to Stephen. You did identify and then articulate.
Miriam.
Oh, Miriam. sorry, Miriam. We are pressed for time.
Yeah.
Apologies for that. All right, so Miriam, once again, apologies. So MSF, you have for many years advocated for more affordable pneumococcal conjugate vaccine, and now you have access to the Gavi prize for pneumococcal conjugate vaccine to protect children, especially in humanitarian settings. How is this working out? And are you hopeful that all of the focus now on reaching 0-dose children can trigger rapid decline in child mortality in the highest risk community, especially with a lot of experience from the continent of Africa? Over to you, Miriam.
Thank you. We have a reputation of being a little bit outsider, but I didn't expect to be out of the panel. Okay. For us, we can access Gavi prize for PCV and now also for rotavirus through a mechanism that is called humanitarian mechanism. And this is a last resource mechanism for manufacturers to sell vaccine at Gavi price, manufacturer Pfizer and GlaxoSmithKline, to humanitarian organizations, not only MSF, Save the Children, other organizations, and also UN agencies outside of the Gavi countries, like UNICEF, IOM, UNRWA has used this mechanism. So the eligibility for this mechanism is not based in income, it's based in a situation of emergency that is graded by WHO. So there is WHO having the certificate of emergency situation or humanitarian crisis situation. And I want to be very specific in the idea of income is not the criteria, because we have used this humanitarian mechanism in middle-income countries, like or not Gavi-eligible countries, like Syria, when it was not a Gavi-eligible country. We have used this mechanism to vaccinate refugees in Greece, here in Europe, and we have used this mechanism for a specific population in Central African Republic, Niger, IDPs and refugees, in natural disaster, in conflict. So there is many scenarios where this mechanism can be used. What we need for this mechanism to work is, first, we need to have policies, national policies, flexible enough to allow the use of these vaccines about 1 year, about 2 years, if possible. So we will always aim to reach children up to 5. And for this, we need national policies to be updated, because the WHO recommendation is clear. And we need the capacity or the permission from the different Ministry of Health to supply the vaccine. In some countries, we are ready to use the mechanism, but we cannot supply the vaccine because we don't have an importation permit. So countries that this is not for national introduction, this will not serve for a general introduction in a country, but for specific cases can be used for PCV and rotavirus vaccine. So imagine in a place like Somalia, that last year was in a food insecurity situation, a big crisis, if we can use this vaccine for children in the nutrition system, in the nutrition program. Maybe not for the full population, but for the nutrition program. But we are sending back children home without PCV or without rotavirus, because it's not yet introduced in the country. This mechanism can serve a specific vulnerable population for PCV and rotavirus.
All right. Thank you so much, Miriam. So quickly, we have around 5 more minutes. Yeah. So please, 1 minute just to summarize. Yeah. So let me use my discretion here. So let me start with you, Zakia. How important is vaccine prioritization?
Okay, thank you. It can be difficult to do the prioritization, especially in countries with limited resources, such as low and middle income country. While vaccination program prioritization is critical on how to allocate these limited resources effectively and efficiently to reduce the number of disease. There are several key factors that needs to be considered to ensure that can be rolled out effectively. And I think it's also already mentioned in earlier panel. One is to consider the prevalence and the burden of the disease itself. And then the second is to take into account the effectiveness and safety of the vaccine, because maybe there's several alternatives of the vaccine that a country can choose. And the last thing is the cost effectiveness, and maybe to add also the budget impact analysis, because that's what would be what matter most for example, Ministry of Finance in a country. So that's practice sum up the several key factors that need to be considered.
Thank you, Zakia. Let me move to Masood.
Yeah.
You heard from Stephen that Africa has launched an initiative.
Yeah.
Currently, Africa only produces 1% of its vaccine need.
Yeah.
Come year 2040, they want to start producing 60% of those vaccine needs. What will be Serum Institute of India contribution to this agenda?
Yeah, this is an excellent question. And
1 minute, please. Masood.
Yes. So I will try to summarize the large work what we do, but just to quickly give an answer to Serum Institute of India today has a current capacity of 4 billion doses already existing. Despite that, Aspen collaboration is a classical example of accelerated access of an affordable vaccine remains the core philosophy of the organization. And therefore, despite having such a large capacity, we will keep on exploring. Aspen, you would see, is a multi-vaccine program, and in a year or 18 months to 24 months, you will see some fantastic news coming out of an access and local manufacturing within the African setup. And we will keep on exploring across continent this opportunity to accelerate the local manufacturing feasibility and possibility, and provide the major contribution what we do today in a change setup going forward.
Thank you, Masood. Let me come back to my brother, Stephen. Today, we know that we've launched this Partnership for Vaccine Manufacturing agenda in Africa. And we know that Africa cannot do it alone. We need the big farmers, like Serum Institute India. We need Gavi. We need the private sector. So if I'm to give you an open check, what exactly will you request from these partners? Over to Stephen.
No, thanks. I think, first of all, charity begins at home. So African countries must agree to pool the procurement of vaccines together. Once they do that, they will be creating the market that is required to sustain the businesses that would support the vaccines that are produced within the continent. Now, so that's the first thing. The second thing is for the partners, be it Gavi, UNICEF, the big pharma, everybody else, what they need to do, first of all, is to fall behind this partnership for African vaccine manufacturing. They must be willing to allow the change in the supply chain as it is today, including of taking a percentage, maybe up to 30%, of the vaccines that are going to be produced in Africa, not only for the African market, but also for the rest of the world. So if they can be able to do that, they will be supporting this effort. Of course, there are questions of tech transfer and everything, and financing, but those two are the most critical that I'll put in my check. Thank you.
Thank you, Stephen. Let me go to Miriam this time around. I don't want to forget you. So, Miriam, you have talked about the humanitarian setting. You've talked about reaching the zero-dose children. So, in your opinion, what sort of package of support, in addition to vaccine, should we be looking at, especially looking at how vulnerable these kids are?
Basic package in terms of vaccine for us is measles, pentavalent because of HIP, PCV, and rotavirus. This is like a standard package, regardless if this is included in the calendar or not, because we are speaking about humanitarian setting. But we also try to include other preventive activities for malaria and for nutrition. What we do is an evaluation of the main killers, and we try to do a comprehensive package that include vaccines, for sure, but can tackle other main killers.
Thank you, Miriam. So let me go to the professor, Fiona. So you've shared your experience as far as the Asia-Pacific region is concerned. We know that we still have around 49% of children who remain unprotected. So what is the single most important change that needs to happen for us to get to this 49% of kids who are unprotected?
Yeah, well, the vaccine cost needs to come down. There is really no doubt about that. We really are, failing to meet the needs of our children with a vaccine that's not affordable for all of our kids. Countries shouldn't be put in a position where they can't prevent their children from dying because they can't afford the interventions, and in this case, vaccines. We all know that this is completely immoral. So there really needs to be a radical rethink on these global mechanisms so that every child, every person that needs a vaccine can be able to access it and a country can afford, and cost should not be an issue. And this includes middle-income countries. So PAHO has a certain price, but PAHO has hoped that these prices would come down over the years, and they haven't. So if all middle-income, low-income countries and middle-income countries got together, the purchasing power would be enormous. For a middle-income country, and we heard from Indonesia this morning, how much it's going to cost once they don't get AMC prices. To vaccinate a child in a middle-income country is $86. To fully vaccinate them with EPI plus the 3 so-called new vaccines, PCV, rotavirus, and HPV vaccine. I mean, that is just an unacceptable price to be paying. And so some middle-income countries, in fact, can't, are getting higher prices than high-income countries because they don't have the purchasing power and they don't have the haggling ability to be able to push those prices down far enough. So, and there's so many underutilised vaccines because countries just can't afford to use them, and this has to change.
So, colleagues, ladies and gentlemen, thank you. I won't attempt to summarize, but just to highlight some key points. One, we heard from Stephen, the fact that access to vaccine is also a security issue. And as a continent of 1.3 billion in Africa, you cannot continue to import vaccines. So we need to continue to have a robust discussion around rural and local manufacturing. Fiona, you have really emphasized the importance of bringing down the cost of vaccine. And I'm sure Masood is just next to you. He has heard you loud and clear. And you also emphasize the importance of pool procurement.
Yeah.
We should bring our comparative advantage, our differential strength together to be able to buy this in volume so that we can bring down the price. Miriam, you have emphasized the importance of reaching those zero-dose children, especially in humanitarian setting. And from what we heard this morning, close to 80% of these zero-dose children are actually in the conflict-averted areas. We are largely in the low and middle income countries. And of course, the cost effectiveness analysis for the political leaders to be able to make an investment case for, vaccines was also clearly highlighted by Zakia. Bosud, we know that you're a businessman, and as part of your corporate social responsibility, we're really glad that you have been able to look into those affordable, vaccines as part of perhaps your corporate social responsibility to bring the price down so that this is something that is affordable by the majority in the low and middle income countries. But much more importantly, the vaccine manufacturing agenda in Africa, in Indonesia, need to be supported by big pharma like you guys. So colleagues, ladies and gentlemen, that brings us to the end of this particular session. Thank you for your attention, and enjoy the rest of the day.
Thank you. Thank you.
Thank you.
And thank you to Dr. Tajuddin and his panel. There's a lot to think about coming out of that, and I hope we'll have time to discuss that as we go forward. We're now actually going to have an input on RSV vaccines, and we're going to have a special input. Please welcome to the podium Dr. Padmini Srikantia.
Thank you so much, Theo, and thank you so much to the organizers for giving me and giving us the opportunity to talk about respiratory syncytial virus today. Let me introduce myself first. My name is Padmini Srikantia. I am a Deputy Director in the Bill and Melinda Gates Foundation in the Pneumonia and Pandemic Preparedness team, where I lead our foundation's strategy on respiratory syncytial virus. So we've heard over the last day quite a bit about progress in achieving goals in child survival. And over the last several years, a number of our speakers have talked about achieving reductions in child and infant mortality, due both to progress in socioeconomic indicators, but also, of course, to the incredible impact of vaccines, and in particular on vaccines that are impacting older infants and mortality among older infants. But we've also heard a little bit about the slower decline of mortality in the youngest populations, in the youngest infants. And today I want to talk a little bit about respiratory syncytial virus, which is the leading cause of pneumonia in infants under 6 months of age, and an important contributor to deaths in this age group. We're at an exciting moment for respiratory syncytial virus because after many decades, we are finally at the precipice of the introduction, the likely introduction of efficacious immunization products to address this mortality. So over the next 20 or so minutes, I'll discuss the basic considerations of RSV prevention, including RSV burden, forthcoming products for RSV, in preventing RSV in early life, and talk through a high-level overview of priorities and opportunities on the road to RSV prevention. So first on RSV disease burden. In 2022, the global annual RSV burden estimates were updated and published in The Lancet. And these estimates found that in 2019, a staggering 33 million episodes of RSV occurred, of acute lower respiratory tract infection occurred in children under 5, causing approximately 3.5 million hospitalizations and over 100,000 RSV deaths among children in the less than 5 age group worldwide. Overall, RSV accounts for 2% of all global mortality in the under 5 age range, and in particular, close to 4% of all-cause mortality in infants under 6 months of age. Indeed, in infants under 6 months of age, RSV accounts for 20% of acute lower respiratory tract infection episodes, making it one of the leading causes of pneumonia in this age group. And almost half of all global RSV deaths in the under 5 age group occur among infants less than 6 months of age. So what is RSV, or respiratory syncytial virus? So virtually everyone gets RSV at some point in their lives, usually by 2 years of age. RSV disease is often mild, like a cold, but especially in young infants can be quite severe and in many cases deadly, or in some cases deadly. Transmission can occur through sneezing or coughing and transference from contaminated surfaces. And repeated infections can occur over a lifespan. Although any child can get ill and severely ill due to RSV, resulting in hospitalization, children are at highest risk if they are under 6 months of age, have co-infections, or live in a socioeconomically disadvantaged area. The first few months of life are the most vulnerable for RSV due to the ease with which an infant's small airways can be blocked. Serious complications of RSV include bronchiolitis and pneumonia and can lead to long-term complications in lung health. In fact, data from South Africa and other countries suggest that severe RSV related to hospitalization in the first 6 months of life can lead to a 3 times increase of recurrent lower respiratory tract infections later in infancy and childhood. To put things in perspective, RSV is responsible for 1 in 28 deaths that occur before 6 months of age, a tragedy that is destined to continue until we're able to really successfully prevent it. What's more, 98% of RSV deaths occur in low and middle income countries. As this graphic shows, in the panel on the leftmost is high income countries, and in the middle panel is low income countries. And you can see this very big differential where there's hardly any color in the left panel, and the right panel is blazing in pink. Children in low-income countries are less likely to have adequate access to medical care and so are far more likely to die from RSV than those in high-income countries, an unacceptable disparity. To break it down further, RSV deaths among children, infants 6 months of age and younger in low and middle-income countries are 4 times more likely to occur in the community, that in pink, than in the hospital, that in purple. And this is often because the vast majority of children and infants with a severe RSV sometimes do not make it to the hospital, where they can receive supportive care, and this lack of access to supportive care increases their likelihood of dying. Causes of death in the community are often unknown and unreported, and as such, RSV morbidity and mortality in many low-income countries is thought to be even greater than what we may already estimate and what current estimates already suggest. So what can we do currently about RSV? Well, current treatment measures are limited to supportive care, such as oxygen, and complicated, in fact, as I just mentioned, by poor access to care or scarce resources in many parts of the world. There are no antiviral medications that are licensed for RSV, and indeed, because of the prevalence of RSV, inappropriate antibiotic use used to treat a widespread disease like RSV may also contribute to the growing crisis of antibiotic resistance. Until recently, the only available preventive agent for RSV has been a monoclonal antibody called palivizumab. This palivizumab is recommended for use in very limited settings in the highest risk infants as a monthly injection with 5 monthly doses administered during the RSV season in preterm infants. This product, which is both difficult to administer and very costly, has been both unaffordable and impractical for most countries and is really only limited to use in high-income countries. However, as I alluded to earlier, it's an exciting moment for RSV prevention. In November of 2022, just a few months ago, a new long-acting monoclonal antibody called nirsevimab was approved in Europe and is designed to be given at birth or soon thereafter to protect in early life. Unlike palivizumab, this monoclonal antibody is a long-acting monoclonal antibody delivered in a single dose is really the wave of the future for providing longer-lasting protection compared to palivizumab. Price and supply are expected to be early barriers for access to this longer-acting monoclonal antibody. But however, we will need market-shaping efforts to overcome these price barriers. Nevertheless, this idea of a long-acting prophylactic monoclonal antibody is promising and promises to be a game-changing class of prevention products against RSV. The other product, or the other type of product for RSV, is a vaccine. And thus far, there is no licensed vaccine that prevents RSV infection in young infants. However, that also may be about to change. A maternal vaccine given to pregnant women in their second or third trimester of pregnancy in pregnancy is being submitted for licensure after demonstrating positive efficacy and results in phase 3 clinical evaluation. And I'll tell you more about these two modalities, a long-acting prophylactic monoclonal antibody, as well as a maternal vaccine, in a few minutes. But first, I want to also mention that the impacts of RSV go beyond illness and death. The lack of prevention means that families and health systems have to bear the brunt of the economic impact of managing RSV cases and complications. Existing and emerging data show that RSV causes substantial economic burden on livelihoods and health systems across the spectrum of country income levels. A single hospitalization for RSV in Malawi is estimated to cause, estimated at 32% of a household's monthly income. In Bangladesh, this ranges from 24 to 32% of a monthly income, and particularly impacting poorer families. In addition, there are costs to the health system. The median annual direct cost of hospitalization in Bangladesh is around $10 million US. And studies across a number of African countries have shown that 5 to 10% of annual hospital admissions among children less than 5 years of age are due to RSV. So successful and widespread prevention of RSV can go a long way towards freeing up these beds, freeing up these resources, both for families and healthcare systems. So let's talk a little bit more about these exciting new forthcoming prevention products. As I mentioned, there are two approaches. One is a long-acting monoclonal antibody, the other is a maternal vaccine. Both approaches are designed to provide passive protection to the infant via antibodies in the early, most vulnerable months of life. The immune target for both of these products is a surface protein on the RSV virus called the F protein or fusion protein. Monoclonal antibodies are designed to attach to the F protein that the virus uses to infect the body. And what's new about nirsevimab and other monoclonal antibodies is that, as I mentioned, they have these extended half-lives, so they are longer lasting than their predecessor palivizumab, and only need a single administration at the time of birth or prior to the season of RSV to protect over the course of the first several months of life. Maternal vaccines are designed to be provided during pregnancy and are another way to generate antibodies for newborns and enhance maternal immunity. So the mom gets the vaccine during pregnancy, her antibody levels are enhanced, transferred across the placenta, and the infant is born with protective antibodies against RSV. Vaccination needs to be timed during pregnancy, ideally in the second or second or early third trimester, to maximize the antibodies transferred to the baby. So the first new monoclonal antibody out of the pipeline is nirsevimab, which is made by AstraZeneca and Sanofi Pasteur, and recently approved in Europe, as I mentioned. The pooled phase 2b and 3 clinical trial data show that the vaccine's efficacy over the first 150 days of life is close to 80% for medically attended lower respiratory tract infection, as well as, similarly, 77% for medically attended lower respiratory tract infection with hospitalization. Right now, We don't necessarily expect this product to be globally accessible in the near term due to price and supply constraints. However, as I mentioned earlier, these long-acting monoclonal antibodies set the stage for a new wave of protection against RSV in the future, and other monoclonal antibodies are in development that could be more readily affordable, including one that the Gates Foundation is supporting development of. The maternal vaccine is developed by Pfizer, and this has also demonstrated efficacy and safety in phase 3 clinical evaluation in 2022. It's also under evaluation for licensure and will be reviewed by the FDA in just a few weeks. In their phase 3 trial, the vaccine showed an 81% efficacy against severe lower respiratory tract infection due to RSV in the first 90 days of life, and 69% efficacy against the same severe RSV lower respiratory tract infection at 6 months of life. Given the high burden of RSV and that the virus is so widespread, such efficacy either for the monoclonal or the vaccine mean that a large number of cases, deaths, and hospitalizations can be prevented for a good impact. For the maternal vaccine, the goal for this product is submission for WHO pre-qualification to be eligible for procurement through Gavi, and we are hoping that pre-qualification can occur as early as 2024 and certainly hopefully by 2025 or 26. So let's talk a little bit about how we get to the point of achieving RSV prevention in low and middle income countries. So it's important to recognize that due to RSV's global nature, preventive products will have a dual market in both high and low middle income countries. To afford these products in the poorest countries, Gavi, the Vaccine and Market Shaping Alliance, will need to provide support. Currently, as many of you are already aware, 54 countries are eligible for Gavi support. Gavi voted in its last vaccine investment strategy in 2018 to support RSV immunization products, whether maternal immunization or long-acting monoclonal antibodies, pending a licensed product, a SAGE recommendation by WHO, a WHO pre-qualification, and as long as the cost is within an anticipated and acceptable price window for impact. We don't yet know exactly what the cost of the products will be, but we anticipate that the cost of monoclonal antibodies may be higher than that of vaccines based on the cost of goods. However, I would like to also mention that the Gates Foundation has made an investment for the maternal vaccine, a $27.5 million investment to support the development of a multi-dose vial for delivery in Gavi markets of the Pfizer maternal vaccine. For public sector purchase. And so this is the vaccine that we hope will be available for Gavi markets in the coming few years at an affordable price. So while maternal vaccines as well as monoclonal antibodies offer protection for young infants, their target populations for administration differ and therefore will require different strategies for delivery. These delivery strategies are likely to be via two platforms. The EPI platform, which is familiar to many of us already, and the maternal and child health platforms, particularly for the delivery of maternal vaccines through antenatal care services. But both platforms will likely intersect to some degree for either product. The path through country introduction for either intervention will vary widely based on the choice of product, delivery platform selected, hierarchy of care, and other factors. RSV is a new disease for many countries, and implementing these products may involve some unfamiliar territory. And therefore, we need careful consideration at the global, regional, and country levels when we plan around what introduction we'll need to take and to successfully roll out these prevention products. We know that many countries have competing public health priorities, and RSV would be a new disease target for many. But we know also, and we believe also, that RSV prevention has the potential to complement many of these priorities. Listed here are some of these initiatives where synergies and efficiencies can be achieved between RSV prevention and immunization and antenatal care strategies, whether supporting the administration of other birth dose antigens for a monoclonal antibody that is given at birth for an infant, or supporting a stronger implementation of antenatal care, providing an incentive for a woman to come to antenatal care for the opportunity for vaccination to protect her unborn infant. Overall, the goal will be to ensure that RSV prevention adds value, not burden, to already strained health care services and competing priorities. There are several domains and activities that we need to think about as countries start to consider RSV prevention. These include the case for prioritizing RSV, including local, regional, burden data, and health economic factors, such as cost effectiveness, cost of illness, and cost of product delivery. These are efforts that we at the Foundation are supporting to generate data in low and middle income countries. Determinants informing product choice, including product safety and efficacy and cost-benefit ratios, will undoubtedly also be important. The regulatory and policy environment must also be conducive to the selected product approval and adoption, and may involve some uncharted territory, particularly for prophylactic antibodies that have thus far not been utilized routinely in EPI programs. Identifying optimal delivery platforms, feasibility and systemic readiness via the EPI or ANC platforms is key, including implementation and supply management strategies, and leveraging existing platforms to pave the way for vaccines intended for pregnant women. Raising awareness about RSV, like we're doing today, and the prevention products in the pipeline among key stakeholders, like those of you in the audience, policymakers, health providers, and parents, will be essential. And part of this will be understanding what are the community perceptions and understanding for new RSV interventions, designing appropriate and implementing appropriate and effective communication strategies. Making progress towards capacity building for safety monitoring and disease surveillance system to track RSV product performance, including pregnancy outcomes, will also be needed in the coming few years. And of course, as with any new vaccination product, workforce readiness will be also an important factor, especially when it comes to the need for ANC and EPI intersections working in conjunction with each other and taking on and dividing labor. And finally, equitable access will depend on financing being in place, which will hinge on fit within country public health budgets and the upcoming Gavi support around RSV. So what's next? Well, right now we have an opportunity with RSV. We have a need to improve our understanding of the RSV burden, not just at a global level, but also at the regional and country level. We also know that there are new life-saving prevention tools on the horizon, and now is the time for countries to begin to consider how best to take advantage of this public health opportunity. Listed here are just some of the questions that we need to start thinking about and discussing. RSV has too long been in the shadows, sickening and killing young children and especially young infants under the age of 6 months. And this has all been in the absence of effective interventions and prevention products. And now we're finally on the cusp of being able to change that. So I'm really pleased to share this summary of what RSV is, the burden, and what opportunities we have coming in the next few years, and look forward to working with all of you to achieve that. Thank you very much.
Thank you very much, Padmini. It's always, I find, really exciting to hear about new interventions, new possibilities. Though it's also really interesting that Padmini raised some of the issues that were raised in the previous panels today, which sets an agenda really for what we need to do before that product is ready to make sure it's truly accessible, affordable, sustainable. So thank you very much, Padmini. And now we're going to move into a discussion around the pipeline of next generation pneumococcal vaccines. I'm really pleased to introduce to the stage Dr. Keith Klugman from the Bill and Melinda Gates Foundation and his panel. I'm very excited because I just found out he's the brother of a friend of mine.
So, thank you, Theo. can't tell you guys how exciting it is for me to be up here talking about a next generation pneumococcal vaccine. For those of us who have been involved in the development of pneumococcal vaccines over the past 30 years, it is wonderful and exciting not only to see the rollout of the existing products, which have saved many, many hundreds of thousands of lives, but also to think to the future. So I want to take you a little bit back in time. The first generation of pneumococcal conjugate vaccine was a vaccine that protected against 7 serotypes. So you'll be aware that there are many different serotypes of pneumococci, more than 100, but fortunately, only a small fraction of those types cause the vast majority of disease. So the 7 types in the first vaccine, surprise, surprise, were designed for the children of the United States of America. And it was rolled out there and used in the US and then in Europe. That was in 2000. The second generation of products, the first of them was a 13-valent vaccine. And there's a range of products, in my view, in the second generation between 10 and 15 serotypes, which for the first time included the most important serotypes in poor countries, serotype 1 and serotype 5. So that was the beginning of the rollout of PCV globally, around 2009, 2010, and we could call those the second generation. And as we've heard at this meeting, there's still a way to go, but there've been major rollouts, especially over the last few years, with huge countries like India and Indonesia successfully rolling out the second generation vaccines. But this panel is about the future, and we need to start talking about it now, even though these products will still be coming in a few years' time, because it takes a long time to make next generation products. So we're going to talk today about what I would call the third generation pneumococcal conjugate vaccines, which I'm defining as 20 plus serotypes. So these products will protect, hopefully, against at least 20 serotypes. So it's extraordinary because the technology has improved, the ability to make the vaccines is improving. So it is certainly our hope that a 20-valent vaccine is not going to cost much more than the existing 10 to 15 valent, and maybe even in some circumstances maybe less expensive. But of course the question is, well, do we need them? And you've already seen data at this meeting that we do. So the CHAMPS mortality studies have identified pneumococci still as the leading cause of pneumonia associated with death in children at the CHAMP site. So how is this possible? Because all of these CHAMP sites have PCV already, either 10 or 13 valent. And the reason is that the pneumococcus is such an important cause of mortality, especially in children from 6 months to 2 years of age, that the non-vaccine types, these additional types which could be included in the 20-valent vaccine, are still a significant and important cause of mortality and therefore need to be prevented. So I'm delighted to have on stage with me 3 people who are uniquely in a position to talk about the next generation of pneumococcal vaccines. I have right next to me here Veronica Denti, who is the Senior Program Manager, New Vaccine Programs for Gavi. And I know she's very excited to be talking to us about Gavi's approach to next generation pneumococcal vaccines. I have Mathieu Poirier, who is the Global Commercial Access Programs Lead for Pfizer. And then finally, we have Yves Lecamp, who is the CEO of Inventprise, which is also engaged in making a next generation, third generation pneumococcal conjugate vaccine. So now I would like to ask Veronica to tell us a little bit about expanding the vision of Gavi. We know, and we have discussed a lot, Gavi's approach to rolling out the current vaccines, especially we've been focused at this meeting about the pledges to the poorest countries in the world, those with humanitarian crises, and the very exciting opportunities that Gavi have announced at this meeting to waive co-pays and to allow the use of these products. But these are the existing products. What is Gavi's view about the next generation PCBs?
Thank you, Keith. And it is true, I am very excited to be here today to talk about the next generation, the third generation of PCV vaccines. And the reason is because all of you have a role to play, including journalists, including CSOs, including obviously the ministries of health. We all have a collective responsibility. As an alliance, our commitment when it comes to the next generation of PCVs is to enable a sustainable, evidence-based, and predictable uptake of this innovation. And I've heard some of the lines that were said earlier today by Dr. Alam, by Dr. Padmini, by our colleagues in Guinea, and I'll refer to them because some of the challenges and the opportunities really come together. When we think about the next generation, I would like to ground ourselves in what we've learned from the current generation, starting with sustainability. From 2011 to 2016, the Gavi-supported volume of pneumococcal vaccines grew from 20 million up to 120 million. And typically, when the volume goes up, you would expect price to go a little bit down with the efficiencies that come with it. And that did not happen very much. The price stayed stable around $3.5 a dose until multi-dose vials were introduced in 2017. And that drove the price down to $3. And then later on in 2020, we have the most cost-effective pneumococcal vaccine that has been made available through the Serum Institute of India at a cost of $2 per dose. So that reduced the weighted average price that we fund further. And we cannot afford to go back. We cannot afford to lose all these hard-won gains on the affordability that enables the sustainability of innovation and enables the programs in low-income countries to continue. And I'd like to echo, we heard from Indonesia this morning that that was one of the limits to uptake, and we hear it also from the most fragile countries as well. So it's important that as we think about the next generation, as you said, Keith, we keep the cost and the pricing related to it in check to consider the affordability to countries. And I'll get back to it at the end, because there's a key role that we all have to play to support manufacturers to do that. It cannot be done alone. The second dimension is evidence-based choice. And we've just seen in the RSV presentation how the Gavi criteria to include a product on the menu were 5, and they included being pre-qualified by WHO, they included the SAGE, meeting the SAGE considerations on schedule, on use, on target population. They also include reliable supply, which is not always a given, and they also include country demand. Somebody needs to be the early adopter. Somebody needs to want this innovation. And for that to happen, we need to have tools that enable the assessment of the value of any new vaccine, particularly the 20-valent and plus PCVs, in an evidence-based way. Where are these tools? We've heard from PATH, the contribution of the cost and cold chain calculator. We'll need that for the next generation as well. We're hearing from WHO, the capacity framework that was used in Guinea will allow the country to assess the benefit and the trade-offs of the new innovation. The benefit, hopefully, from an effectiveness and efficacy perspective, and the trade-offs, will it be in a multi-dose vial? Will it be a 3-dose schedule or a schedule that matches what the recommendation will be then? Will it be affordable? Will it be available? Will the availability be reliable? Can we really be sure that there will be continuity of supply? And here is where the alliance brings together UNICEF, WHO, PATH, CHAI, all the technical partners to support the governments of the early adopting countries having the evidence to ground their decisions in. And we need that because our UNICEF counterparts need to know how to award a contract. What is the demand? We cannot have predictable supply, and this is the third aspect that we hope to support, without predictable demand. So for predictable demand, we need an evidence-based choice, and for predictable supply, we need to know who are going to be the countries that will take these countries on, the products on first, at what cost, what is the predictability of the cost going forward, and what are the volumes going to be. And as you can imagine, we'll need to play a role across all the manufacturer, because there might be one front runner, others that come with the multivalence, and from a Gavi, a UNICEF supply division will echo the perspective as well. We'll need to support a balance between supply and demand. We really need to support markets to be healthy, to ensure continuity of supply, and to ensure the best products being available to the countries that demand them at the right time. So to enable this predictability, we all need to come together, because there is a gap in awareness. I pause here, because that gap we saw the first time in 2020, when the new PCV became available with an advantage that seemed to be evident to some countries, not to all, because value is very country specific. And we didn't see the awareness being there at the NITAG level, at the EPI level. So we are addressing now this gap by reinforcing our collaboration with the Global NITAG Network, so that the Global NITAG Network can be informed and share what is in the pipeline and what is the value of what is in the pipeline for the technical advisory groups in the countries to be equipped, knowing what's coming, and to have the tools and to have the evidence to make their recommendation for the adoption, sooner or later, of that innovation that needs to match the country needs. So that's where we need a collective effort to ensure that the awareness is sustained. It doesn't happen in one meeting. It doesn't happen in one phone call. It happens over and over. New data being released, new evidence coming forward, new tools being developed. We really need to keep equipping our counterparts in countries as much as possible with the awareness and the tools to assess the value of these new innovations. Thank you.
Well, thank you, Veronica. So that's some really useful and important ideas for us going forward, so that the world is prepared for the next generation. So I'm now going to ask Mathieu about the next generation Pfizer product. So in August of last year, Pfizer announced the results of their 20-valent vaccine. And I'm very excited that you are with us today, because this is not a vaccine that is yet licensed anywhere. So I am delighted that you are prepared to even talk about access of this vaccine to the world's poorest communities. So tell us how you are thinking about this at this early stage.
Yes, thank you. So first, I would like to thank the organizing committee for the invitation to participate to this important event. So I'm really delighted to be with all of you today. Just before we jump into what are our plans for access for this PCV 20, I just want to give you a bit of detail of the Pfizer commitment to pneumonia. So for more than 20 years, Pfizer has been a global partner in battling pneumococcal disease through continuous vaccine innovation, expertise in battling new pneumococcal disease serotypes, and also working with health communities, partners, to make sure we're able to bring the latest innovation to people who need the most. We introduced, as mentioned by Dr. Klugman, the first PCV in 2000, so more than 20 years ago. And after that, we expanded with the PCV 13 in 2010. Unfortunately, I have heard for the last a day and a half that it's not enough, that we need additional product with additional serotype. And fortunately, there are some serotypes that are included in our PCV20 that hopefully will be helpful in the future. So to go back to the question, so where are we with our PCV20? So the PCV20 adult indication is already approved in both FDA and EMEA for use also in established and adopted in a number of countries. For the pediatric indication, which I think is more important for the audience today, Pfizer initiated in 2020 the phase 3 clinical trial program. And as mentioned also by Dr. Klugman, the first result were initially shared in last August. From a regulatory perspective, where do we stand? So we have submitted what we named the supplemental biologic license application. So for people that are familiar, the SBLAs for PCV20, again in both FDA and EMEA for the pediatric indication. With the EMEA serving as the reference regulatory for the WHO pre-qualification, this is an important step for us to make sure that we'll be able to submit this product to WHO and enable access to low to middle income countries. And speaking about access, what is our commitment to make sure this new candidate will be available? We are hoping to continue to work closely with Gavi and all the other partners that are in this important partnership. And we hope that we'll be able to reach as soon as possible and offer the product to low to middle income countries. Thank you.
Thanks so much. So in contrast, I guess I have to say to Pfizer that everybody knows about, there is a new company called InventPrize, which the Bill and Melinda Gates Foundation is helping fund to think about a next generation 25-valent vaccine focused on the serotypes that cause disease in the poorest parts of the world. So, Yves, how do you expect this vaccine to roll out once you have made it? Tell us something about this vaccine.
Thank you, Dr. Klugman, and thank you for pronouncing the name of the company properly, InventPrize. This is Invention Enterprise. And indeed, making such a complex vaccine available to all will be a great achievement for everybody. And I think there are probably three main elements that will help us achieve that implementation. And the first one would be the science, the technology. How can we develop a better vaccine? And we spoke about the PCV7, but before PCV7, there was an Haemophilus influenza type B vaccine, HIB, first conjugate vaccine, which has now been implemented in most vaccination programs on a worldwide basis. In 2015, we were contacted by the National Research Center in Canada, who asked us to develop a novel Haemophilus influenza type A vaccine for the native population living in the Arctic Circle and potentially helping addressing the burden of disease of that small community with that novel vaccine. The profile of the vaccine needed a very strong initial immune response and also a long-term duration of protection typical for conjugate vaccine. Now, the scientists of InventPrize looked at that profile and quickly realized that a traditional conjugation method would not achieve that goal. So we looked at how to make a better conjugate. And as you know, a conjugate is a polysaccharide against which you want to elicit an immune response, and a carrier protein which is attached, conjugated to that polysaccharide, which is generating the long-term immune response. And through the literature, we saw that by spacing those two components, by including a linker, we could generate a better immune response. We tested a few linkers and we selected one which is now in the vaccine. So that's the first element about the science. The second is about economics, about smart manufacturing. How can we manufacture sufficient volume at an affordable price? And in that, there is a question of the complexity of manufacturing. And each step in manufacturing, when you do a filtration, when you do chromatography, you lose a bit of the product. So if you can redesign the process by limiting the number of steps, you lose less product as you are manufacturing the vaccine, and therefore you have a better cost. Another element which is important is the scale of production. And at each step of production, you need to do a quality control. This is a test, this is an expensive test. And you need to do that 25 times because you essentially do 25 vaccines in one go. And this amounts to hundreds of tests for a batch of vaccine. Now, you have to make the same amount of tests irrespective of the size of the batch. So if you make a very large batch, you can spread the cost of those tests over a larger number of doses and reducing the cost of each dose. Another element is to make things, you need labor and you need equipment, capital investment. I'm coming from Switzerland, and I thought that Switzerland was the most expensive country in the world, and then I relocated to North America, to Seattle, and it was a big surprise. So Seattle is a nice city, and it's an expensive city, and as a result, labor cost is very expensive. So how can we make an affordable vaccine in such a location? The other dimension is capital equipment. And a German fermenter, an Italian filling line, a Swedish centrifuge will cost the same if you install it in India, in Indonesia, in Brazil, or in the US. So we have a high cost of labor and a common cost of equipment. So one of the solutions is to minimize the cost of labor by using automation. And we had a chance to redesign the process to increase the level of automation. And while people need to sleep at night and are taking holidays, a fermenter can work day and night. A bacteria can grow at night. So we have a fully automated process where we can initiate a batch and come back the day after when the batch is completed. There is also a benefit is that through automation, we can better utilize the manufacturing capacity 24 hours per day, 7 days per week, and this way we can make the high volumes which are needed at a low cost that will make it affordable to the population that need it. And probably the third element, and my colleagues mentioned that as well, it's about partnership. And we have been fortunate enough to work together with the National Research Council in Canada, with the foundation, with PATH, and we are very grateful to the step where we are now. This vaccine is in clinic. We have a large-scale manufacturing plant which is being qualified as we speak. And looking forward, we are looking to work together with WHO, Gavi, UNICEF, PAHO, and the countries who are present here and beyond to implement those vaccines. Thank you.
So thanks, Yves. So back to you, Veronica. The audience might say, well, this is a foolish question because obviously more is better. So if you have 20, it's better than 13, and we don't have to discuss more. But maybe we do. So how do you actually assess the value of the next generation products?
Thank you, Keith. And yes, it is easier to think that more is better, and we have seen this criteria being utilized in some countries, or at least to be explained even to healthcare workers, why one is sometimes perhaps similar to another rather than better. So the way we approach this technical question that, for full disclosure, will be addressed in detail by the SAGE committee at WHO from an intrinsic value perspective, what we've learned is that value is specific to a country, and that value is not only based on the quantity of serotypes, but on the impact of that vaccine as many serotypes as it might have in that specific setting. One of the challenges that we have, and I want to thank your team also for bridging the gap there, is that we cannot go and map the serotypes prevalence in every single low-income countries. It would be counterproductive. It's too much of a bigger barrier. So we need to find other ways to have an evidence-based, informed choice about the value based on the impact of the additional serotypes in that country setting. And I know your team is working on building a model for that. So that model can be then discussed with the technical advisory groups in the local setting to see, okay, maybe I get 5-10% more impact against these variable of cost differential against a certain supply availability at a given time. And putting that all together, we really can then help countries assess the value of this innovation for them. And it is important to do this for PCV and for other vaccines, because I also look after other vaccines where there are 5 versus 1 or 9 versus others, and sometimes it is not a linear relation, not at all. It is important that we look at the impact and not only at the formulation of the vaccine.
So thanks, Veronica. So Mathieu, we've been discussing at this meeting rolling out PCV in some of the most difficult places on the planet. We heard earlier just today about how Gavi is thinking about Somalia and South Sudan and dividing the areas into those areas where there's so much conflict that they can't even get in. So giving life-saving product, often it's actually your product. So how does a company based in a very rich country work in these environments? You've had 20 years of experience. How has it gone?
I mean, we learn a lot over these 20 years, and the impact of these partnerships has been remarkable. I think we have seen that over the last few hours and few days. And one thing that we learn is exactly these partnerships could be impactful when all the organizations are working together. So if we think about the last decade for Pfizer, between 2010 and 2019, the PCV that is commercialized under the name of Prevnar 13 is estimated to have averted more than 175 million of pneumococcal disease cases and around 625,000 of death of children below 5 years old. So it's not only Pfizer, it's all these partnerships. So it does work when everyone is working together. So that's one of the big lessons that we learned. And from a Prevnar perspective, now we have the product that is available in multiple national immunization programs around the world. The thing is, unfortunately, what I learned and what we discussed over the last few days is with the pandemic that happened, this pandemic impacted a lot the great work that has been done over these last years. And in some places, we're almost back to square one, or there were some backsliding. So we need to rethink about how we will be able to vaccinate these people. So a lot of children have not received the vaccination that they should have. So the second lesson that we learn around this partnership is we need to make sure that the production capacity is important, because even if you mentioned that sometimes we try our best to predict the forecast and the demand, is sometimes difficult. So at Pfizer, what I'm proud to say is 1 dose every out of 2 doses, so more than 50% of the doses that are produced for PCV13 are for the world poorest countries and at the lowest global price according to our partnership with Gavi and partners. So this is something that we are really proud. In terms of numbers, what it means, and as of today, we have been able to deliver more than 820 million of doses in these low and low middle income countries. So for us, this is another important lesson. But we don't want to stop there. We want to continue this partnership with the industry, with the other partners, to make sure that we will remain committed to supporting and to the strong partnership that we have built along these years. So we're also proud to mention that we have extended this partnership with Gavi and partners until 2030, so we'll be there for the long run. In addition to partnership like this one with UNICEF and Gavi and other partners, we are proud of another initiative that has been launched in May 2022 by our CEO. Maybe some of you have heard about that initiative under the name of the Accord for a Healthier World, which is focusing on enabling access to innovative medicine and vaccines. So in fact, the full portfolio of Pfizer to reach more than 1.2 billion of people in 45 lower income countries. So as part of this engagement, Pfizer, as I mentioned, is committed to offer the full portfolio of medicine to vaccine that we have global right at a non-for-profit basis. In addition, everything that will come in the future from a vaccine and medicine perspective, where we will also hold the global rights, we are also committed to offer this product at a non-for-profit basis in the targeted accord countries. The thing is, even if we are able to supply this product at a non-for-profit price in these countries, it's sometimes not enough. Supply is one thing in the equation, so that's why we are also continue to working closely like we do in partnership like we have with Gavi and UNICEF. We are looking at other partners. We're looking to make sure we have good discussion with government so that we not only think about the product itself, but we're able to make sure that there will be health system in place that will support diagnosis infrastructure so that when it will be time to use the product, everything will be in place, because product by itself will not solve all the challenges that we have in lower income countries. However, I want to make it clear, this accord is a wonderful project that has been launched a little bit less than a year ago, but it will not replace the traditional channels that we have in partnership with UNICEF and partners. In fact, the objective is to complement this type of partnership and rather find some synergies and make sure we can have a stronger footprint and help even more the lower and low and middle income countries. Thank you.
Well, thanks, Matthias. So before I summarize our session, you have an opportunity, Yves, to tell us about this kind of unique business that you're the CEO of. You're calling it a mission-driven vaccine manufacturer. Tell us how you are different.
Thank you, Dr. Kligman. So yes, it probably goes back to the origin of the company, and the company was founded by Dr. Capre, and Dr. Subhash Capre had been working for over 45 years in India, developing and manufacturing very large scale, very large quantities of vaccine for distribution in emerging countries. And after a long career, he decided to step back and retire and spend more time with his daughter, who had relocated to Seattle. So he traveled to Seattle and started indeed to spend some time with his daughter, but also to meet former colleagues and acquaintances at the foundation. And he was asked by the foundation to do some consulting. So during 1 year, he had been traveling around the world, helping other manufacturers to improve their manufacturing process and generally helping people. After 1 year, he said he wanted to be more involved in developing vaccines that were affecting child mortality. Created a small laboratory, 600 square feet in downtown Seattle, recruited 1 employee, and then little by little acquired some more projects. And we mentioned the discussion with the National Research Council in Canada. And now we are 10 years later with about 150 people, 2 research laboratories, 1 medium-scale manufacturing plant for clinical manufacturing, and 1 large-scale commercial plant. So doing vaccines for emerging countries in our DNA, and all the team which is there is thinking in the same direction. And it's also translating in the kind of targets that we are following, that we are targeting for our vaccine. And definitely one is the pneumococcal conjugate vaccine. And initially it was a 6-valent vaccine that we were developing with a Japanese company. And that's where we could witness that by adding more antigen, we didn't see that drop in immunity that other large conjugate vaccine are seeing. We increased the number of antigen to 12, and we discussed with the foundation, maybe we can do co-vaccination of a PCV13 and a PCV12, and then we said if we can do 12, maybe we can do 25, and together with the foundation and PATH, we selected those strains which are most prevalent in emerging countries. So this is also translating in the selection of the targets and the antigen. And we do the same for a number of other vaccines. So we will do the same for a heat-stable Rota vaccine, looking at the heat stability. It will also be looking at how do we present the first vaccine, and we think about LMIC first. So the first presentation will be a multi-dose vial presentation to limit the burden on the transportation and on the cold chain, we will develop a pre-filled syringe later. It's also about capacity. I mentioned about capacity, to have very large-scale capacity to be able to meet the demand of the country. It will be about thermal stability, I mentioned for ROTA. It will be about administration method. We are also developing a microneedle array patch, which would hopefully, if the system works, to be able to do away with syringes and needles for some antigen, the sharps, and the disposable of contaminated sharps. So these are all elements that we consider when we develop a vaccine. And at the same time, we will also make those vaccines available to high-income countries. We want to make our vaccine available to everywhere. The high income countries can also benefit. We are fortunate to be located in the USA with a highly regulated environment, so we can make the same high quality vaccine available to all, and probably through that also recoup and distribute the cost of research and development on a larger basis. So this is our mission, this is what we are doing.
So thanks, Yves. So I know that we're sort of sitting between you guys and lunch, so I'm going to summarize some aspects of this really fascinating discussion. So in the first question then that I asked Veronica about Gavi's view on the next generation PCV, she pointed out that price is critical. And I think we all know that, but she went beyond price to talk about evidence-based choice, so that ultimately the next generation vaccine is going to have to be considered in terms of the advantages that it offers, in terms of increased coverage, but at the same time there's a trade-off in effectiveness and affordability. And then I thought one of the really interesting things she mentioned was engaging the global NITAG network. So NITAGs, as you all know, are the committees that recommend vaccines, and this needs to be done early, before the vaccine even has its WHO pre-qualification. And then finally, Veronica mentioned the importance of knowing global serotypes, and obviously we at the Gates Foundation are funding studies to do that, and then coming up with an impact model. With Pfizer, the initial question was what is happening with the 20-valent, and we heard that for children, it's in fact been submitted to WHO for pre-qualification, which is extraordinarily exciting. And then Mattia pointed out, I thought, some very impressive numbers. He said that the Pfizer vaccine has prevented 175 million pneumococcal infections, which translates to 625,000 deaths that have been averted. And that is extraordinary. And that even though obviously the vaccine has been sold for large amounts of money in rich countries, more than 50% of the vaccine is in LMICs, and 820 million doses have gone to LMICs. So I think we're very excited and hopeful that that will continue with the next generation product. And then finally, Yves talked about this new entity, which is being set up in Seattle, and he talked about the new technology, this linker, which they believe may help to make a more immunogenic product, and also spoke about how they are aiming to reduce costs by having a large scale, but with increased automation. And then finally, he paid tribute to the genius behind all of this, Dr. Subhash Kapre, and said that, in fact, vaccine for poor countries is in their DNA. So with that, here's hoping. We know that the pneumococcus remains a formidable foe, but at the same time, it does appear that there's at least one vaccine which is very close to licensure. There's another one that will be coming down the line. There are actually other manufacturers who are not on the stage today, who also are trying to make 20-plus pneumococcal conjugate vaccines. So I think that we are cautiously optimistic that these vaccines will come, and that when they come, they'll come at affordable prices, and very quickly after they become available in rich countries. So thank you all for your fascinating discussion, and thanks to the audience for your attention.
Thank you. Thank you.
And thank you to Dr. Keith Klugman and his panel for raising some really important issues around access, around affordability, and around strategies.
Those numbers, those numbers.
Well done, guys.
We've got one last thing before
Excellent summary at the end. I should have taken note.
From lunch. It's a really exciting session. I think we all know that Indonesia actually achieved SDG 3.2 in 2019, pre-pandemic, and they have managed to hold on to the progress that they've made. There are so many lessons to be learned from how they achieved this, and we are very, very lucky, and I am delighted to welcome onto the stage the Honorable Dr. Amish Alumami, who's the Deputy Minister for Human Development, Society and Cultural Affairs from the Ministry of National Development Planning, Indonesia. Dr. Alumami.
Thank you. Very good afternoon, ladies and gentlemen. Let me introduce myself first. My name is Amih Al-Humami, currently serving as Deputy Minister for Human Development, Societal and Cultural Affairs. I would like to talk about lessons learned on how Indonesia achieved SDGs, especially goals number 3.2. Distinguished guests, ladies and gentlemen, it is a great privilege for me to be here representing the government of Indonesia to participate in this very important forum. And I would like to express my gratitude to the organizer for inviting us to the second global conference on pneumonia to share with all the participants on the progress and lessons learned in achieving SDGs to reduce child mortality. As pneumonia is a leading and major cause of child death, we are truly aware that we couldn't achieve targets on reducing child mortality without addressing it seriously. At the first global conference on the subject, held in Barcelona in January 2022, our Minister of Development Planning affirmed Indonesia's commitment to reduce child mortality and to expand PCV vaccination program and vaccine provision through a funds market mechanism. This commitment became the basis for PCV vaccination, which has been implemented in Indonesia. 2 years later, with a great deal of effort, we have been able to scale up the PCV vaccination across the country, covering all 34 provinces and reaching 514 districts, with various targets achieved among them. In this sense, the government of Indonesia has asserted that fighting pneumonia is one of the main strategies to reduce child mortality, and we put it on the very high priority in the health sector development. Ladies and gentlemen, the 2030 SDGs agenda is a path to more prosperous, equal, and sustainable future life. This is an agenda for people, the planet, and their well-being. To strengthen its implementation, we have integrated the SDGs agenda into the National Medium-Term Development Plan by detailing policies and programs related to the targets and indicators of SDGs. In 2022, we have achieved impressive progress in carrying out SDGs. Of the 222 indicators for which data is available, around 78% of them have been achieved and are progressing towards better achievements. In this strategic forum, we are proudly share with all of you several lessons learned on how Indonesia has been so far on the right track to achieving the target of SDGs, especially Goal 3.2 for child mortality in 2030, while still continuing to connect all the dots of strategies, maintaining and trying to achieve better results. Ladies and gentlemen, last 2 years, we had bitter experiences as the COVID-19 pandemic hit all countries globally, causing a major shock in almost all people's life, including the economy, employment, and health. Especially, healthcare was disrupted and overreach resulted from the global pandemics. Several SDGs targets such as poverty reduction and lessening unemployment have been affected by the COVID-19 pandemic. So all these targets have to be revised. Nevertheless, SDGs targeted at maternal and child health and nutrition are progressing well, even during the pandemic. Maternal mortality, child mortality, stunting, and wasting have shown significant progress. Meanwhile, the country's population census shows that Indonesia has significantly reduced maternal mortality rates from 360 in 2000 to 189 in 2021 per 100,000 live birth, and the child mortality rate from 26,000 to 16.85 per thousand live birth between 2010 and 2021. Stunting among children under 5 years of age also constantly reduced for the last 10 years. With this progress, we believe that we can achieve our 5-yearly medium-term target by 2024. Ladies and gentlemen, I believe that one of the very key factors for the success in reducing child mortality owes to the government firm on its programs and their funding by setting those targets as the national priority. The first lesson learned is that the government has established defined goals and strategies to reduce child mortality and placed the agenda as a priority in the medium-term development plan 2020 and 2024, which is then translated into the Ministry of Health Strategic Plan 2020 and 2024. These documents indicate massive support from the government, especially to gain national and subnational commitment to secure budget for child death, for child health, and to guide local government to implement the program in the field. The intervention and target have been discussed and secured through an annual trilateral meeting involving line ministries, the Ministry of Health, the Ministry of Planning, the Ministry of Finance, while maintaining monitoring and evaluation. Another key success as the second lesson learned that we want to share is localizing SDGs and making SDGs achievement equal to all areas and communities. The Ministry of National Development Planning has coordinated and facilitated the SDGs Regional Action Plan at the provincial levels, which involves district governments and non-government stakeholders. Indonesia has also developed a roadmap for the implementation of the SDGs, which provide guidance for stakeholders to navigate tasks that are quite complex to achieve the goals and targets of the 2030 agenda. Moreover, we have encouraged related parties to establish SDG centers, especially at universities and other institutions. And until now, accumulatively, 37 SDG centers have been formed throughout the countries. These SDG centers become strategic partners for the government, especially in the context of providing data analysis and policy recommendation to improve the implementation of the SDGs agenda. The third lesson learned, the Ministry of National Development Planning, together with the Ministry of Health, are also committed to the implementation of the government initiative called Health System Reforms, one of the only two major projects initiatives started in 2022 and carried to 2024 to ramp up the existing strategies. The health system reform has positive impacts on the setting of the quick win intervention to mitigate the pandemic, as well as regulatory reforms which are not limited to these three aspects: maternal, child, and productive health. Several policies aim at strengthening primary health care, such as increasing the minimum number of antenatal care visits from 4 to 6, providing all health centers with ultrasound examination facilities, enhancing equitable distribution of healthcare professionals, and providing bolstered referral system. One of the main focuses on this reform is to harness the budgeting strategies. We have a strong commitment from the central government to fund health development through special transfer fund to be allocated to district government. This budget designated to both strengthen primary and referral care, covering medical devices provision, for instance, cold chain, emergency services, providing access for mother to nutrition services during their pregnancy. We also make sure that every pregnant mother has access to delivery service at modern health facilities through mandated social health insurance. And the government provides full and partial premium subsidy to the insurance for the poor and informal workers. The next lesson learned is that we have complementary interventions. Here, I would like to emphasize that IMR reduction targets could not be achieved by solely relying on IMR-specific activities. Instead, it also owes to the other concrete programs, including, number one, expanding basic immunization coverage and comprehensive management of severe and acute malnutrition. Integrating immunization as one of the specific interventions in massive campaign in stunting reduction programs. Increasing awareness of the community as well as the national leadership on the importance of prevention through vaccination. Decreasing total fertility close to net replacement rate, continues declining in child marriage and teenage pregnancy, and expanding premarital health sessions. Ladies and gentlemen, despite major achievement in child mortality reduction, major challenges still remain. For example, there are some unfinished business in PCV vaccination. The coverage of immunization, including PCV, is still low and uneven among provinces and districts. Participation from private healthcare and for immunization is still limited. National immunization registry has not been yet 100% compiled by the local government. Moreover, a low level of immunization literacy among communities leads to the rejection of multiple injection of the PCV vaccines. Our next challenge in Indonesia would be to ensure the effectiveness and also a better capacity to implement an integrated PCV vaccination as part of the basic immunization programs. Ladies and gentlemen, finally, we would like to express our sincere appreciation for holding this event. We really appreciate the support and collaboration of the La Caixa Foundation, the Bill and Melinda Gates Foundation, Gavi Alliance, and UNICEF. Learning from the past, we have to push our effort to address development challenges that might contribute to the achievement of the SDGs in order to provide better responses for accommodating dynamic development, especially in reducing child mortality.
We expect through this activity, we can learn from each other how to reduce child mortality, and at the same time, we encourage all of us to strive and ramp up the effort of child mortality reduction. Be prepared for any challenge that lie ahead. To conclude, we are confident that within the next coming years, the government of Indonesia will make a better contribution to achieving the SDGs, which can be shared to the global communities. Thank you.
And thank you so much to the Honourable Dr. not just for his remarks, but also to the people of Indonesia for that extra motivation of knowing that a country can achieve SDG 3.2, which gives all of us extra motivation and very much comes down to what Dr. Endi was saying earlier this morning: government leadership, country ownership, strong partnerships, and as the Honourable Minister just said, ensuring that we don't work in silos but have a more holistic, rounded approach to the work we're doing. So I know that people are very hungry now, and we are going to release you for lunch. Just before you go, to remind you, lunch is in the foyer again today for everyone. There is a lunch and learn session, which again will be in the room Aula 1. And that lunch and learn session is about next generation pneumonia research and researchers. So please, if you're interested, pick up your lunch, go to Aula 1 and join the lunch and learn session. And the third lunch is for people who already know and have been invited. There is a private Child Survival Action Partners lunch, and that is taking place on the 4th floor. You will already have been invited to that if you're meant to be going there. So those are the 3 options for lunch. Please remember to sign the declaration if you haven't already signed it. And please, if we could ask everybody to be back here at 2:30 in your seats. We'd like to get going this afternoon. We have an exciting program, lots to learn, lots to share. So have a very good lunch, and we'll see you in just over an hour.